Good morning, everybody. It is so great to see you here today. My name is Rebecca Andrade, and I'm the Educational Programs Manager here at the Kansas Health Institute. And I would like to welcome you to the second annual Health on the Plains Summit. Then, a little bit about who we are. The Kansas Health Institute, or KHI, is a nonprofit, nonpartisan educational organization based in Topeka. We were established in 1995 with a multi-year grant from the Kansas Health Foundation, and we are guided by the vision that Kansas will become the healthiest place to live through evidence-based and innovative strategies, policies, and practices. We work towards this vision by providing nonpartisan information, convening crucial conversations, and facilitating learning that leads to meaningful change, just like today's event. And then before we begin, I would like to take a moment to acknowledge Wenche Lin, Carrie Breathitt, and Victoria Sergova for the subject matter expertise. And we'd also like to acknowledge those who are part of the convening planning team, Lindsay Burkhart and Carson DeWeese. And it is now my pleasure to introduce Wyatt Beckman. Wyatt is a senior analyst and portfolio strategist here at KHI, and he will be facilitating today's welcome as well as moderating one of the panels. Over to you, Wyatt.
Thank you so much, Rebecca, and thank you all for being here. Uh, this this is the second annual Health on the Plains Summit, and we're so thrilled to have you all here and to do this event again this year. And like last year, our goal is to create a space for engaging and nuanced conversations around topics impacting the health of Kansans, of rural Kansans. And we know lots of people from all different sectors have a role in shaping their communities. And likely, if you're here today, you have a role in shaping health in your community, your state, or the groups you serve. We also recognize that our rural communities have unique assets and challenges. Ultimately, we believe we can develop better policies, more effective programs, and more innovative solutions by learning together in these conversations. Now, the focus of this year's summit is not on one single health topic. Today, we're going to talk about rural health funding. Now, when I put those words on screen, I imagine that you all have some initial thoughts, maybe some emotions that come to mind seeing rural health funding. And I invite you in chat to share some of those thoughts. Uh, what is that phrase? Those three simple words. What does it elicit? And what does it make you feel? Whether that's positive or negative. And thank you for folks that have started to add some comments. I imagine, and I'm seeing some of this in chat, that some of those feelings, some of those thoughts are challenging, or we need it, or shifting. But for others, you may feel optimistic. You may think about words like opportunity or collaboration, or maybe some of all of that. Today, we hope to make space for all of those feelings, all of those insights by wrestling with this question throughout today. How can collaboration and innovation help fund and sustain rural health efforts? And by the end, I hope we walk away with a deeper understanding and some new insights that we can all collectively put to use to support the rural communities we serve. This is what our day looks like today. And we're going to start with an opening presentation by my colleague Shelby, who I'll introduce here in a second. And as you can see from the agenda, we know rural health funding is a really big topic. We're going to wrestle with two key aspects or two key angles today. We're going to talk about federal funding for rural health, and then we're going to talk about philanthropy and non-governmental funding. In that first panel, Shelby will facilitate. We'll take a very brief break, and we'll invite you all to stick around and come back for a really great second panel that I'll facilitate. Now, we know there's lots of ways you all can spend your time, and we appreciate you're here. We want this to be really valuable for you. One of the ways we hope to support your learning and engagement is through our resource guide. Uh, Lindsay has dropped that in chat for you. Feel free to use this resource guide to further engage with the information today. It's got some discussion questions for you to think about, some links to additional resources, and a space to take some notes. Ultimately, though, we hope that you gain some new thoughts, maybe ask some new questions today, and have some new ideas for how to move forward. We appreciate you giving up your time to be here. And with that, I'm going to turn it over and introduce my colleague, Shelby. Shelby is a really key part of our team here at KHI. And I have had opportunity to work with her on many of our rural focused efforts. And she's a tremendous asset to KHI. And she is the lead author on some work she's going to share with you today. And will facilitate that first panel. And Shelby, without any further ado, I'll pass to you and we'll kick off this great summit today.
Thank you so much, Wyatt. Thank you for the warm welcome. So, to start today's conversation, I saw in the chat when Wyatt was asking about how do we think about rural funding. I saw a lot of confusing, and I think this next slide shows just how confusing the federal landscape can be for a rural issue. So this visual gives us a broad look at what the full range of federal support for rural communities looks like, not just rural health. Because so many different agencies touch rural communities, it means the funding landscape can be very complicated to navigate. So even though this chart covers rural support broadly, it helps us explain why the rural health funding landscape feels as complex as it does. So to take a closer look into the rural health landscape specifically, we know that federal or rural health initiatives are interwoven across agencies, with each one playing a unique role in addressing the needs of those rural communities. So the first agency that we'll look at today is the Health Resources and Services Administration, which houses the Federal Office of Rural Health Policy, one of the main federal entities focused on rural health. Next, we have the Centers for Disease Control and Prevention, which houses the CDC Office of Rural Health, which strengthens rural public health through data, prevention, capacity building, and for health departments. And then next we have CMS, and CMS helps shape rural health through a variety of different ways, including Medicare and Medicaid policies. And they also oversee the Rural Health Transformation Program, which we'll dig into a little bit later. And then finally, like we saw in that lovely chart, I think Wyatt calls it a spaghetti chart, there's so many other agencies that maybe don't have a health focus, but do touch different grant programs that contribute to health across the country. So agencies like the Department of Agriculture, the Department of Transportation, as well as the Department for Housing and Urban Development. So now that we have a better understanding of who are the players within rural health, we can take a closer look at how federal grants flow down to communities. And obviously, this is not a comprehensive look at how federal dollars get to rural communities, but I do think it shows us kind of a broad overview of how those grant dollars get down to those communities. So we start at that congressional appropriation where Congress determines what funding and what types of programs will be funding. From there, it goes to various federal agencies that distribute grants. FORP is a huge part of that. And once the federal agencies, send out those notice of funding opportunities, within our analysis, we saw three main categories. So the funding can go directly to a rural community organization. It can go to large organizations that serve rural communities, like universities, national associations, and other organizations of that nature, or it could go to state government. And when it goes to state government, it can take a few different pathways. First, it could stay with that state agency, say a state health agency, to help them run programs that are focused on rural health. or it could be passed through to different organizations such as community-based organizations, healthcare facilities, as well as other statewide organizations that serve rural health. So the next slide that we'll see just gives us a little bit of an overview of the series that I'll be discussing today. So we'll be looking at the data and findings from KHI's Funding Rural Health series, which examines how the Federal Office of Rural Health Policy supports communities in Kansas and across the country. So just to get started, for context, here's how we defined awards for this analysis. So one award equals one grant for one grantee in 1 year. So one. Those multi-year grants or cooperative agreements, those were counted once per year. It also, throughout the different visuals you'll see here in many of our charts and tables, the funding amounts were rounded to the nearest $100,000. So next, looking at the role of HRSA's Federal Office of Rural Health Policy, FORP was created by Section 711 of the Social Security Act in 1987, and it performs a variety of duties. The six that I want to highlight is it provides national leadership on rural health policy. It administers a variety of programs to support rural health care. It coordinates rural health activities within HHS. It also conducts and supports various types of policy analysis and research. It supports innovations in rural healthcare delivery, and it supports the state offices of rural health at that state level, at KDHE, or at the Kansas level, it's housed in KDHE. And this is an organization or an office that really supports rural health within our states. So on this next slide, we'll see kind of digging down deeper into what FORP funds. So on this table, you'll see that we divided all FORP awards, all 4,088 awards that were included in our analysis across those 75 programs from 2019 to 2023, and we categorized those into 7 different primary focus areas. So the funding amount, it totaled about 2.3 billion nationwide, and within Kansas, the grantees in Kansas received about 75 awards during this period. So just a few data points I want to cover. Nationally and in Kansas, the largest number of awards went to healthcare access and service delivery, but by the dollars, the biggest share of funding went to the COVID-19 response, and nationally that was 29%, and then in Kansas it was 49%. So nearly half of the funding that FORP provided for Kansas-based grantees went to that COVID-19 response. So next, looking a little bit more in more detail about that COVID-19 response and how it impacted FORP funding, it created a major but temporary surge in FORP funding. COVID awards came very quickly in 2020. They peaked in 2021, but by 2022, they nearly disappeared while that non-COVID funding stayed relatively stable. So nationally, this spike was driven by pandemic-specific programs, so things like testing or other mitigation strategy funding, which significantly increased total FORP dollars during this time period. So within the states experienced that surge very differently, which we don't have the visual on our slide deck today, but I highly recommend if you're wanting to learn more about how your state experienced that funding to check out Figure 4 on our FORP brief, which you'll get in your resource packet. But again, this COVID funding dramatically reshaped the rural funding landscape within that short period. But now we're relatively back to stable. So looking at our next slide, this is just taking a more of a look at the percentage of FORP funding that went to recipients located in fully FORP rural counties per state. So as we can see, states vary dramatically across this, with some states being as low as 0% all the way up to 100% in New Hampshire, I believe. So by number of awards that Kansas Kansas received, Kansas closely mirrors that national picture. So about 53% of those awards in Kansas went to fully FORP rural areas compared to 53% nationally, and about 43% went to grantees in not fully FORP rural counties. But by the dollars, that tells a different story. So we see that only 14% of that FORP funding went to grantees located in fully rural counties. So next slide, we'll be taking a closer look into the distribution of these awards within Kansas. So just to point out this map, we have it divided by regions just for illustrative purposes only. So I think it gives us a better idea of how different parts of the state have been impacted by FORP awards, but again, that is for illustrative purposes only. So as we can see, Kansas received 71.9 million in FORP funding from 2019 to 2023, which ranked the seventh highest among all states in total dollars awarded. So as a part of our Funding Rural Health series, in that resource packet that you have, you can access 3 different fact sheets that take a closer look into some of the specific programs that FORP funds that different recipients or grantees receive during this time period. So I highly recommend checking those resources out just to get a closer idea of the types of programs that FORP funds. So next slide, what can we learn from these funding patterns? We know that FORP plays a key role in expanding access to high quality care in rural communities. We know that the programs themselves can vary widely in focus, size, and requirements, ranging from small local projects to large national initiatives. This variation shapes who applies and who receives those different awards. And then we also know that a significant share of those total dollars flow to not fully rural city-based organizations that serve rural communities statewide and nationally. And these groups typically have more capacity to apply for and manage those grants. So at the same time, those smaller rural organizations may face capacity challenges when they're applying for or managing those competitive federal grant dollars. So now that we have a better idea of FORP, we're going to take a quick look at the CDC. So CDC has supported rural health efforts for many years across its centers and programs, but the creation of the Office of Rural Health formalized and centralized this work. So the Office of Rural Health's vision is a stronger, more capable rural public health system, and its purpose is to advance rural public health science and practice through a coordinated and strategic approach. So as you can see, OHR's focuses on 3 core areas, including strategy, program integration, and science and innovation. So now digging a little bit into the Rural Public Health Strategic Plan, which one of our panelists, Diane Hall, will help us explore more deeply. But the Rural Public Health Strategic Plan is a new initiative, and the years that it will be in effect is 2024 to 2029. As you can see, this plan is grounded in extensive input by both internal and external partners. And those 4 major priority areas are improving results by strengthening engagement in with rural partners and communities, strengthening rural public health infrastructure and workforce, an area where many rural communities face those persistent challenges, advancing rural public health science, including better data and evidence for what works in rural settings, and then also improving preparedness and response capacity, which ensures that rural communities are better equipped for future emergencies. So now we'll turn our attention to the role of Centers for Medicare and Medicaid Services. So CMS plays a major role in shaping rural health through payment and reimbursement policies that affect rural hospitals, clinics, and providers. CMS is also home to the Office of Minority Health, which has a rural health program that works to identify rural disparities and advance equitable access through data, policy guidance, and tools that support underserved rural communities. And it also serves rural communities through programs like the newly established Rural Health Transformation Program. So taking a closer look at the Rural Health Transformation Program, we're going to take a very high-level overview of this. There's so many different great resources that already exist that dive deep into this application and dive deep into the program itself. But the Rural Health Transformation Program is a new major federal initiative that's designed to strengthen rural communities and rural health systems at scale. It provides 10 billion per year for 5 years, beginning next year, which is a historic level of sustained investment dedicated specifically for rural health transformation. This program supports a broad set of activities, including things like prevention, access to care, workforce, as well as value-based care models, which allows states to take a comprehensive but tailored approach. So with this application and program, the applications were due on November 5th of this year, and states are expected to be notified for the funding determinations by December 31st. So now taking a high-level overview of Kansas's program application, this process was informed by the Kansas Rural Health Innovation Alliance, which really helped inform and shape Kansas's rural health transformation application by identifying priorities and needs from rural stakeholders. So the Kansas Rural Health Transformation Program is anchored in a set of core values that shape how decisions are made and how priorities are set. Building from those values, the state established 5 program objectives, which are the high-level goals of the plan that are designed, that the plan is designed to achieve. Next, under those values or the values and the program objectives, we have initiatives. So there's 5 different initiatives that outline how Kansas intends to reach those goals, and each initiative includes specific programs, projects, and targeted outcomes that really bring those brings the plan to life and shows how Kansas is going to accomplish those initiatives. If you'd like to learn more about the application and what's included in it, I highly recommend checking out KDHE's website for more information. The application is available on their website. So our next slide, we've gone over a lot of information in a short amount of time, hopefully not too quickly, but I think from this presentation, we can see that the rural health funding landscape is complex, diverse, and it's constantly evolving. Today's presentation primarily focused on federal funding and federal agencies, but we know that rural health support comes from a variety of partners, including state and local governments, philanthropic organizations, community-based partners, and regional collaboratives. So with that, our panels today will help us take a closer look both at the federal funding and federal partners side of that landscape, as well as philanthropic and other non-governmental resources that support rural communities. So with that, we'll go ahead and turn to our first panel. I'm going to take a sip of water really quick because that was very quick. Sorry about that. Alrighty. So as we've seen in our introductory presentation, the federal landscape shaping rural health is complex, broad, and deeply interconnected. Understanding how these programs work and how funding reaches local communities is essential for anyone trying to strengthen rural health systems. To help make sense of that picture from the federal perspective and to better understand how these national priorities are operationalized on the ground, including their impact in Kansas, I'm pleased to move us into our first panel and introduce 3 rural health leaders who work every day at the center of these efforts. So first, we have Dr. Diane Hall. She is the director of the CDC Office of Rural Health, where she leads the agency's rural public health strategy and works with CDC programs to ensure rural is considered in all CDC activities. Previously, Diane was a senior health scientist in CDC's Office of the Associate Director for Policy and Strategy, where she served as CDC's rural health lead, led CDC's public-private partnerships work, and supervised workforce development activities. Diane also held several leadership positions within the CDC's COVID-19 response. Diane began her CDC career as a scientist in the Division of Violence Prevention. Prior to coming to CDC, Diane held an academic appointment at the University of Pennsylvania, where she taught courses on the theories of psychotherapy, psychology of women, and adolescent development. Next, I'm pleased to introduce Tom Morris, the Associate Administrator of the Federal Office of Rural Health Policy within the Health Resources and Services Administration of the U.S. Department of Health and Human Services, or HHS. In that role, Tom oversees the work of the Federal Office of Rural Health Policy, which is charged with advising the Secretary on rural health issues. The office, which has an annual budget of $364 million, administers a range of research and capacity building grant programs that serve rural communities. And next, I'm pleased to introduce Jody Schmidt, who serves as the Executive Director of the University of Kansas Health Systems Care Collaborative, a rural clinically integrated network launched a decade ago through a Centers for Medicare and Medicaid Healthcare Innovation Award. With more than 3 decades of experience in rural hospital and clinic administration, she is a past president of the National Rural Health Association and a representative to the American Hospital Association's Small and Rural Hospital Governing Council. She is also a past chair of the Kansas Hospital Education and Research Foundation and a member of the Kansas Hospital Association's Rural Emergency Hospital Task Force and Sunflower Health Plan's Rural and Community Advisory Boards. So thank you to all 3 of you for joining our conversation today. I am so excited to learn from all of you, and I know our audience is too. So to begin, we'll be focusing on federal priorities, roles, and coordination. Throughout the presentation, we saw federal investment in rural health spans multiple agencies from CDC, HRSA, CMS, USDA, and a number of others, each playing a distinct role. At the same time, rural needs are interconnected and require a coordinated response. So we'll begin by exploring how these federal priorities are set and how this multi-agency landscape functions in practice. So Diane, let's go ahead and start with you. Although we know that CDC has been doing rural health work for decades, the CDC Office of Rural Health is one of the newest pieces of the federal rural health infrastructure. Can you give us more detail on how and why the CDC Office of Rural Health was established and how its formalization in 2023 has helped shape CDC's approach to rural health priorities and coordination across programs?
Great. Thanks, Shelby. Yeah, as you mentioned, CDC has been doing work since we first opened our doors 79 years ago. We'll be 80 next year. But often that work was at the program level, and it often relied on a small group of dedicated staff. So it was decentralized. That meant that projects and work wasn't always visible, and they were not evenly distributed across the agency. That started to shift in 2017 with the publication of our Morbidity and Mortality Weekly Report Rural Health Series, or MMWR. And I often say that what was in those reports was nothing surprising to anyone that was familiar with rural or did work in that space, but to everybody else, it was pretty shocking. And it brought significant attention to CDC's rural public health work, and that became the catalyst for CDC leadership to identify a single agency point of contact and coordinator for our rural work. CDC is really large with many centers, and we can be a tough nut to crack. And so the thinking was that if we had one point of contact, that would help rural partners better know how to find information at CDC. And it was my privilege to serve in that role starting in 2017. I often joke that I was the person saying, "What about rural?" in pretty much every meeting I attended. Someone asked me at that point what I wanted for rural. And I said, you know what, at that point, you know what, I'm just going to keep doing rural stuff. It was on top of other work that I was doing, but it quickly became my favorite work. And what I said in answer to that question, I wanted rural communities not to feel overlooked or left behind. A lot of times it's just easier to go to the area where there's the most population. There's a bias in our thinking toward thinking about urban first. And I was hoping that we could change that. So in those early years, We really focused on building capacity at CDC through workshops and training sessions. We brought in a lot of experts to come and train our staff. We also focused on developing relationships with partners, and Tom Morris and his staff were such a huge help on that. And in retrospect, and I've said this before, thank goodness we started on creating good relationships in 2017, because trying to do that during a pandemic would have made things even more challenging. So by the time 2020 rolled around, partners knew who we were, they knew how to contact me, and we had those good relationships. It also meant that I could then bring them into conversations with my colleagues across the agency. So these were steps in the right direction, I thought. But the approach still wasn't formal and it wasn't systematic. And we really wanted to be more strategic and intentional and systematic in our work, and really hoped that having an office that was mandated to serve that role would help with that. So in fiscal year 23, appropriations were directed to CDC to create an Office of Rural Health. We received a budget of 5 million. People said that's not very much money, but we were trying to do stuff with 0 million before that. And so 5 million is a good place to start. I was also selected as director, and that meant there was now an office at the agency that could solely focus on building rural work. And it's the thing I get to focus on with 100% of my time. So I'm just thrilled by that. Um, the other thing you mentioned, why CDC has a very different focus than other parts of the government, including other parts of HHS. So we are focused on prevention. We're focused on providing support to the public health infrastructure, the public health workforce, and really thinking about the health of a population as a whole. So I mentioned that that's not a lot of funding. It allows us to do some things, and I'll talk a little bit more about that in a bit. But it's not enough to provide grant funding. So you can't apply to our office for grant funding at this point. 5 million just isn't a lot to go around. But it does allow us to be proactive and strategically coordinate across the agency and to fund the development of rural resources. So we're in a position of influence at CDC. I don't have the funding for a lot of things, but through working with our experts across the agency, I can influence how they write their funding announcements. I can influence their thinking around setting up a community of practice or TA or things like that. But one of our first activities, and this was directed in the appropriations language, was to develop a rural public health strategic plan for CDC. And this is the first time CDC ever had something like this. It was published in September of 2024, and we've been focusing on implementation and action since then. Since the establishment of our office, we've grown from a team of 3 to 10. Which has allowed us to really lead internal efforts to build capacity, better inform the rural work at the agency, and support investments and projects. About 75% of that $5 million goes out the door for projects that focus on research and data, identifying rural public health needs and best practices, developing trainings and professional development opportunities, and implementation of our plan. We do have an action group that is comprised of people across the agency who are rural champions, and they're supporting the development of the strategic plan. And they've identified over 80 different priority activities across the agency. And so it's just been so exciting to see what's happening with this group. I think a lot of times, or maybe it's just me, when people hear strategic planning, they're just like, oh, everybody does strategic planning. And when we enter this, we wanted our strategic plan to be actionable and plain language. We wanted it to be clear to people that this is what we're laying out. We didn't want to wordsmith. We didn't want to argue about terminology. Is it a goal? Is it an objective? Like any of that stuff. We want to focus on action. So we're in the process of developing a dashboard that will track those different activities that action planning team is coming up with. Since the establishment of our office, we've continued to engage with different partners. because partnership's key to our work. We're a small office. We can't, $5 million, we cannot transform public health in rural areas, but working through the rest of the agency and working with partners, we can have some influence. And we get to collaborate in really creative ways, which is really essential. And I do have to say, I'm so happy that I'm not the only one asking what about rural at CDC these days. There are a lot of us doing that, which is really encouraging.
Awesome. Well, thank you so much for sharing. I do have a follow-up question for you. So, with the strategic plan being developed and kind of guiding the agency's work both internally and in terms of collaboration, can you maybe walk us through how having that strategic plan has maybe impacted your collaboration with other federal agencies like FORP or CMS, especially thinking about obviously with the new Rural Health Transformation Program, what did that collaboration process look like once you had that strategic plan to really set forth those priority areas?
That's a great question. Thank you for asking that. So you had mentioned that we were really collaborative and we got input from a lot of people during the development of the plan. I sort of tipped my hand on how I feel about some strategic planning efforts, and I really wanted this to be useful. I wanted it to be something that made sense, and I wanted it to be um, based and grounded in foundational principles that CDC espouses and that are part of a good public health practice. So, we held listening sessions and a town hall and lunch and learns to get that feedback. The four main areas, just, results-based engagement with partners in rural communities. The results-based language there is deliberate. Um, and I make a distinction between partners and your distribution list that you use. A partnership is bidirectional and mutually beneficial, and it's a trusted relationship. It's somebody that you can call at 5:30 on Friday because something just happened and you need to get someone pulled into the loop. That person will take your call. That's a partner. Um, the second is really strengthening the public health infrastructure and workforce. We know that health workers, healthcare, and public health, there have been all sorts of challenges that have been going on for a while now, and rural public health is definitely a part of that. We want to advance the rural public health science. As Tom Morris always says, rural's not small urban. We should not automatically be thinking that what works in an urban area is going to work in a rural area, either because of capacity issues or sometimes just fit. Rural's not the same, but also it's not urban. And so it's not one size fits all. So we really need a better understanding of the science. And then really focusing on that preparedness and response. And a lot of that was informed because of our work with the COVID-19 response. So we think those are foundational, critical areas of focus for the agency. And as I mentioned, our work is mostly through influence, not through direct planning or direct funding, I should say. In terms of implementation of the plan, we are framing it as actions people can take. One of our divisions, this is so great. The person on our action plan development team gathered data on their publications for the past several years to look to see where they did an urban cut of the data. And then started tracking, I see Tom smiling, and then started tracking where there were missed opportunities with which data set and with which authors, and presented that to leadership. And so now they have a baseline and a goal of improving that. Initially, she said she was gathering all these efforts, and all the scientists sent her their publication list. And she said, "Okay, that's great. I'm not sure what's so strategic about a publication list, but let's see what we can figure out." And that's where they came up with the idea to identify some of those missed opportunities and see where there were some leverage points. And so across the board, the action planning team is really continuing to identifying ways to incorporate rural into their portfolio. We do collaborate a lot with other federal partners. I did mention that CDC is different than other areas of HHS. I talk with Tom a lot. USDA a little bit less these days. But we definitely have relationships with USDA, relationships with CMS also. There are parts of CDC that work really, really closely with CMS on a regular basis. And so there's enough work to go around. All of us being in communication together and knowing how to work together is really critically important because we don't want to duplicate efforts. And working together is going to be the best way to tackle things.
Yeah, Tom, I saw you came off mute, so I'm interested to see with Diane's comments, can you maybe talk through from your position in FORB, what does collaboration look like and maybe what have been the differences that you've seen in collaboration since the CDC Office of Rural Health was established?
Well, sure. I mean, it's just great having a partner like Diane and all the folks in that office. We've really benefited from their initial focus on lifting up their investments in rural, but then the formal creation of the office was just it was great to have another Office of Rural Health in HHS somewhere. So I think it's really important. I think since the beginning of our office in 1987, I inherited a tradition of really emphasizing that if we wanted to make an impact on rural health, it had to be beyond our budget. And so we've always sort of focused very heavily on leveraging whatever part of other agencies. If they want to focus on rural, we want to collaborate with them. And so we see ourselves as a resource within government for other folks who may be new to it, but also as a partner. So our door is always open, and we've had a lot of good examples. We've done some close work with the National Cancer Institute because they came to us because they saw lower incidence of cancer and higher mortality in rural areas, and they wanted to know why, and that led to a major initiative on their part. USDA has been a long-term partner. You can't talk about rural health very long without getting into the finance issues, as Jody knows well. And so CMS is a key partner. And so it's as big a part of what we do as running our grant programs.
Thank you, Tom. And kind of to dig deeper into maybe the grant programs and some of the different areas that you see as rising to priorities within this year, can you speak a little bit to looking at everything that FORB does? What are some of the main things you're thinking about going into 2026?
Well, sure. First, I want to thank you all for what you did on the resource guide. Nobody's ever done that before, and when you sent your draft to us, we were like, "Boy, this is great! How do we get the other states to do that?" I just think it's a wonderful resource, and we'll probably steal from some of your graphics as well because we thought those were very well done. And as we think about what's coming up for us this year, our funding is, as you noted, is at two levels. We have funding that goes to communities and funding that goes to states. And I think that with our community-based funding, it has a very important underlying philosophy, and that is how do we create situations in which rural is competing against rural? Because I think one of the challenges, and you spoke to it, and I think Diane did too, in that first chart you had from the Brookings Institute, the spaghetti chart, is a perfect example of that. If we're asking a small health department or a community health center in Western Kansas or a nonprofit organization to find somewhere in their limited resources to apply for a grant, asking them to go up against Topeka or Kansas City or Atlanta makes no sense. It's not fair to those communities. And that's why I think historically we've had some challenges in terms of helping rural communities really leverage the available federal funding. So my hat is off to the Congress and the administration for supporting programs that are specifically focused on rural communities and then creating flexibility within those communities. One of the main grants we have is called the Rural Health Outreach Authority. And what's interesting about that, and there are a handful of programs underneath it, is it's got a very broad statute. It just basically says the grants have to improve access to and coordination of care. And I remember a couple of years going back and asking one of the authors for why they did that, and they were like, because the needs in rural communities are so diverse. If we go on the normal alphabet soup of, D is for diabetes and H is for heart disease, we're just perpetuating some of the challenges rural communities face. So having some very open-ended funding has made a big difference in terms of being able to push resources into rural communities. The other thing, and this I think goes back to the point you made about collaboration, is we're happy to have every one of the 300 million plus dollars we have, and yet we could invest that in one half of Kansas and maybe move the dial a little bit. So, there's no way we're meeting the full need here. We're just trying to do the best we can with the programs we have. And that's why being able to lift up other federal resources and then partnering with philanthropy, I think is really a big part of the challenge. Anyway, as far as thinking about what we're doing this year, one of the big areas we've had of focusing on the last handful of years is on the opioid crisis and the related substance use crisis that has spawned, all of which is also tied to a behavioral health and mental health crisis that we're seeing in rural communities. And so two of the bigger programs that we'll have out this year come under our Rural Community Opioids Response Program. We're going to be offering both planning grants. This is for communities perhaps know they have a challenge here, but are not quite sure what they want to do to address it. But then for communities that have, for lack of a better term, shovel-ready projects, we have our impact awards. And with the impact awards, that's where we're looking at really addressing, giving communities resources to address prevention, treatment, and recovery, and really think through all three phases of that. And so we've been funding grants like that for quite a few years. And the idea behind all of our grants, whether it's our outreach grants or the ARCOR grants, is we're not a permanent funder. We basically are startup funding. The idea being that we're going to invest in your community and your good idea. But part of that agreement is that you all, the awardee community, can then use that funding and that time to then sustain the project long term. And so part of that is really thinking about very intentionally on the front end is like, how do we use this to address some of our immediate needs, but then how do we very quickly pivot to keep as much of it going as possible? And we've had pretty good success in keeping those projects moving, beyond the federal funding grant period. We'll also have some workforce funding this year. We've been funding the creation of new physician residency programs in rural communities. We have research showing that if you can do half of your residency time in a rural community, there's a fivefold likely increase in the probability that that's probably not the right term, but that you'll practice in a rural community. So we have a model that works. If we can get residencies created in rural communities, we know a lot of those doctors are going to stay practicing in rural communities. And so what we fund is the ability for a community, a rural hospital, to get through the accreditation process, set up all the rotations, and then we hand them off to Medicare or Medicaid or state revenues that funds the actual training. And so we've been able to create more than 500 residency slots over the last handful of years. And we've done it not just in family medicine, but we've seen them in psychiatry, and preventive medicine. We just funded our first general surgery residency. And so that may be an opportunity. And we have a TA center because anybody that's worked in Medicare residency in training for residents, particularly on the Medicare side, it's complicated. And so we have a TA center called Rural GME. So if any of you are sort of interested in learning more about this, start with the Rural GME folks. We're also happy to talk to you about it. And I think this will speak to one of the themes that may come up later, which is given limited capacity in rural communities, you really want to be strategic about when you're going to spend your scarce resources on applying for a grant. And we can help you with that to figure out, is now the right year to come in for the opioids funding? Is now the right year to come in for the residency funding or our outreach grants? Because we do realize that putting all those resources into a grant and then not being able to get it is a real challenge. And so there's no guarantees on funding, but we want to be able to help as much as we can. The other area I guess I would note is that we have some funding around the maternity crisis we're seeing in rural communities. So if you're interested in addressing some of the challenges we see with the loss of obstetric units, but then also, the higher maternal mortality rates that we see in rural communities. We do have some communities funding for that. It's well described in your resource guide. And then two other quick areas, just our work with rural hospitals. A lot of that we work through our state offices of rural health, the Kansas State Office of Rural Health. A lot of our efforts to do quality improvement and performance improvement run through that office and then out to the hospitals. But we also have some national programs for hospitals that are perhaps facing a more acute crisis. And so, we'd love to talk more with folks about that. We have a national technical assistance program. We have a new transitions program about value-based care. And we also have a program called Rural Hospital Stabilization to help expand service lines in rural hospitals with the idea of driving more volume and thus increasing more revenue and hopefully putting them on a more sound trajectory moving forward. And then the final area that we've really been focused on is, and Jody spoke to it, didn't speak to it, but you noted that the work they have on their clinically integrated network. I really believe for the independent hospitals that are out there, for the independent clinics, that rural health networks are going to be a key part of the future. Given all the consolidation that's going on in the healthcare system, the ability to help independent providers work together to build size and scale, I think, is going to be critically important to their survivability. And I think the ability to then help them form clinically integrated networks is a really important consideration. And so we'll be doing a pilot program this year where we've tried to recharge our network development program to try to better meet the needs of those networks in terms of really integrating their clinical operations, integrating their business side and administrative operations as well. So stay tuned for that. We are a little delayed in all of our grants because of the shutdown, but we'll hope to get those out in the spring and early summer so that we can make the awards before the end of the fiscal year. And then one final area, Kansas, I think, has already taken advantage of this. We do have funding to help rural hospitals that are considering the new rural emergency hospital designation, where if you give up your inpatient beds, you can still maintain an ED and offer outpatient services. And there's some financial benefits in terms of Medicare reimbursement, as well as a lump sum payment that's made to the REH. This is not the solution to rural hospitals closing, but it may be an option for some rural communities. And the reason I wanted to mention it is because even if you're not sure what you want to do, but you're facing some challenges as a rural hospital, through our TA program, which is the Rural Health Redesign Center in Pennsylvania, they can run an entire pro forma financial and clinical and operational assessment for you. And at least you'll have that information to take to your board so that you can show them that you're looking at all the options out there. And that's at no cost to any of the hospitals. So if you want to know more about that, please follow up as well.
Awesome. Thank you so much, Tom. So, as you noted, I think, Jody, going to you now, you've had a incredible career first as a, well, not first, but as a hospital administrator and now working for the Care Collaborative. So thinking about your role in those organizations as you're hearing the different federal priorities and you track that so closely, how do you kind of make that calculation that Tom was discussing in terms of this is a federal priority? When should an organization, or what are some of the considerations that you as an organization make as you're deciding what opportunities to apply for and maybe what opportunities to hold off on?
An excellent question. And I learned today that I started working in rural health the same year that the Federal Office of Rural Health Policy was formed. So I've had an opportunity to really take advantage of a host of the federal programs that we've discussed today, fortunately, from early network development grants to outreach, et cetera, all the way through CMMI award. And I believe that it starts with, and I agree with Diane, strategic planning can sound like let's develop a plan that we put on a shelf, but actually fine tuning the priorities of your organization first, and then saying, how can I further those priorities through these funding opportunities rather than having the tail wag the dog. We really want to know, to Tom's point, that these are sustainable opportunities, that we're going into the right sets of opportunities, that we're really understanding what we're seeking to achieve and what outcomes we want to be able to measure at the end of these opportunities. And so there are lots and lots of funding that cross our paths. In fact, I'm now very fortunate, having been in, that individual rural hospital CEO situation where we were on our own versus now having the academic team. I do have folks who come to me regularly with these grant opportunities, but we really have to step back and say, we have a board of managers of rural CEOs, a board chair who's a rural physician out of Beloit, Kansas, rural health clinic administrators, rural FQHC folks, who really help us define what are our priorities as a care collaborative, and does it fit with something we have identified as a priority, or that is we're preparing for the future of value-based care, of new partnerships and new ways to assure the financial sustainability of our rural facilities and access to care in our rural communities. Does this fit? And we always do say, as a care collaborative, does it have the potential for sustainability? Not always a guarantee, but can we really look at it as venture capital, if you will, that gives us the dollars we need to kickstart something, but do we have a path forward? And for us, the majority of the time, we have been able to sustain because we approach it that way. You know, when I joined the academic medical center, it's just about 11 years ago now, and I went out and talked with folks. What I heard is very well-intentioned researchers would come out and test new models with us for 2 or 3 years. And then at the end of that grant, they'd pick up their marbles and go home. And we had to figure out, can I sustain this myself? Or do I have to take this service away that I've been able to provide to the patients and the families that I care for in my rural community? And it put folks in a really difficult position. So I do believe that even before you apply for an award, it's important to think through, what are the avenues of sustainability? What payers can I reach out to with the outcomes that I generate from this award to say, we really can move the needle, and we can do it in a way that reduces total cost of care while improving quality, et cetera, so that I can make the case for ongoing reimbursement, so that I can make the case for sustainability from a quality perspective, so that I can really shepherd the resources. Is there a current model? When we launched our CMMI award, it included care coordination. And we went in and we looked at the research, and it said care coordination really only worked about 50% of the time per the research. When we dug into the underlying successful groups, it was those that had a longitudinal trusting relationship between the individual, who we call them health coaches, their care coordinator, and that patient over time. And so we do want to really also look at the research and the evidence to help guide the work that we're doing, in order to, again, make sure that we're going to have the best possible chance to move the needle. Because then again, it gives us the ability to make the case that this should be a sustainable program and a sustainable project. And as a result, we've now been able to do roughly 160,000 chronic care management and remote patient monitoring visits. Because we stepped back and said, okay, what does the research tell us about the right way to do this? So I think there's a lot of planning and a little bit of homework that we need to do on the front end when a funding opportunity comes forward. And I do really appreciate, as Tom was saying, that there have been these sort of open-ended funding opportunities, so that you do have a little bit more flexibility and a little bit more opportunity to address the unique realities of rural, and to see what makes sense for you and your region. As we were providing, in partnership with the governor's office and KDHE and KDAD, some support to the Rural Health Transformation Plan development, we really did try and look at those things that have statewide applicability and impact, but also, hopefully, cross our fingers, create some funding pools that will allow those regional and countywide and specific local initiatives to have the flexibility to submit for funds for something that is unique to them and makes good sense for them. And I do believe that flexibility and the opportunity to explore unique partnerships and to build on the assets that we have as rural communities is really important. It's always been my belief that as rural facilities, and I'll steal this from Alan Morgan because I think he's absolutely right, we have the ability to lead, because, yeah, and I view it as a speedboat. You know, we can move quickly in testing these new models of care, and we can see outcomes quickly given the populations that we serve. Here at the health system, making a change is like, turning a battleship. With nearly 20,000 employees, things don't happen on a dime. But as CEO of a smaller rural community, we had the ability to be flexible. we could deploy a new sepsis protocol and have all of our departments implementing it in 3 weeks. That doesn't happen at a major urban organization. So we have the ability to be that laboratory for new and exciting opportunities to test some of the new practices, to really, we're hoping that we'll have the opportunity to perhaps be the largest test ground for food as medicine in the country. And how can we do that across the rural communities that we're working with? So a lot of effort, I think, has to go in on the planning end. A lot of forethought in terms of who are the partners who have been doing work in this area already, and how might we come together and collaborate in order to move something forward. It is challenging. I know, having been, a single rural organization writing grants, it can sometimes feel challenging to put all of the pieces together to really make a good effort at that application, to really be able to pull together the data that supports the effort that you're seeking. But there are those technical assistance centers, those rural resource centers, et cetera. You aren't alone in finding the information you need to help you really be able to move something forward. And then we're very fortunate here in Kansas that we have some philanthropic organizations that have been willing to provide some funding to support the grant support, so that we can get a little bit of a leg up in being able to do that. And then also be very thoughtful about the capacity of your teams. Much like Diane, we have, as a care collaborative, a pretty small team. We have 91 members across 79 counties, roughly 3/4 of the state. And we have a team that's about the same size as Diane's, and she's covering the whole country. We have to be thoughtful about the capacity of the groups that we have, and can we not just chase the dollars of a grant, but can we really commit the resources to making it a priority, to making it effective, to demonstrating the outcomes that we need, to not stretching ourselves too thin just because we're chasing the dollars. And with so many opportunities and so many new federal programs, we're just yesterday in our staff meeting talking about the new access program that was recently announced. And we don't have a lot of detail yet, but how does it fit in with our current work? Does it make sense to make it a priority and seek to apply? And how does that fit in with some of the new reimbursement models that were released under the physician fee schedule that changes how we need to do our work? There are a lot of moving pieces in making those decisions. And I really do encourage people to be thoughtful. And then once you are active in the implementation, there's also the reporting piece. And so it's important to think about, even when we have the federal funding to do the work, there's the sweat equity that comes into being able to draft the reports and generate the outcomes to prove that your program has been successful. And sometimes, having just helped finalize 3 grant reports myself in this last month, I mean, it is a commitment of time. And we're working right now on a no-cost extension for our HRSA workforce grant. And it's been an incredibly impactful opportunity for those who might never have been able to further their education past high school to become certified medical assistants. Some of these students are telling us it's been life-changing for them. Single mothers, the first in a family to be able to move beyond high school education. Those that are now looking at a broader healthcare career and going to work as a CMA while they train. And incredibly important for our rural health clinics, who are the training grounds for these folks. In most cases, they're offering these CMA students jobs before they've even quite finished their certifications, because they have that need and it's filling an important gap. And so as we're coming to the close of that award and thinking through that final report, it's back to, again, that whole process of, recording the outcomes in a way that we can then seek additional support for the sustainability of the work. So as wonderful as grants are, and I was adding it up in preparation for this work, I think I've been part of somewhere close to $40 million worth of grants in my career. It really is a commitment. and something that people need to, to think about. As a care collaborative, our goal is to make it as easy as possible for folks to adopt evidence-based practice and guidelines and support, and to participate in the Medicare Shared Savings Program, and hopefully down the road, single signature contracting and direct to employer, and telebehavioral health, and launch of a new virtual campus in 2026, and all of these sorts of efforts. Our goal is to really make it as easy as possible, because we know that our rural members have limited resources. And so, but at the same time, we're seeing these really exciting partnerships where 2 or 3 communities are coming together and saying, we all have a gap, we all have a need. How do we as a small group come together and seek an award? And so a really exciting opportunity for that sort of collective impact to happen.
Yeah, I love that framing of one being strategic and also being collaborative and really leveraging the strengths of rural communities, because I think so many times we hear about maybe what's a challenge in rural communities, but we know there's so many strengths. So really building upon those for these different types of grant programs are so important to do. So we'll go ahead and pause here. Wyatt, I'd love to see if we have any questions from our audience that our panelists can help answer.
Yeah, thanks, Shelby. We got a question from Alan, and it goes to Diane and Tom. Curious about CDC and FORP relationships with other federal serving agencies like HUD, economic development folks, food and nutrition, SAMHSA, EPA, etc. Is there a formal hierarchy, sort of guide for how that collaboration happens, or is it more opportunistic? Is it a combination of both? Talk a little bit about that collaboration across other rural serving agencies.
Diane, would you like me to start, or?
Sure, go ahead.
Okay, I apologize for my IT issues, but once I got off our system, it worked just fine. Well, it's a good question, Alan, and I think what's happened is over the course of my career, there's been several times where we've had sort of HHS-wide or government-wide initiatives, and they've happened under multiple administrations. The last one was during the prior Trump administration. And what happens in the course of those is a point of contact is identified for just about every participating agency. And what we've been able to do is use those to sort of reestablish links, because sometimes they're person dependent. But coming out of that, and since that initiative back in 2020, we have a point of contact in just about every part of HHS. And so we collaborate closely with them. And then, as you know, because you helped get started the Rural Health Philanthropy Partnership, we also invited a lot of those folks to come and be part of our meeting with rural focused philanthropies as well. And so, NIH now has a rural group that meets regularly. CMS has had a rural council for years. Now they've got the transformation office. Diane's creation has already been well established today. We've been working, with SAMHSA for a number of years. So it sort of happens informally, but then we try to make sure that we're coordinating as much as we possibly can.
And I would say that Brookings spaghetti chart that was shown, that's hard for you to track. It's hard for us to track too. So a lot of times I never assume that Tom and his office are going to be looped on something if it comes to me first. Tom has been really good at making sure that CDC is looped in on things. I think because we're headquartered in Atlanta, people sometimes forget we're here. And so he will send me something, hey, have you seen this? A lot of times I haven't, and I try to return the favor. But it is complex and it is changing. And I don't like to use the word opportunistic, but it's maybe grassroots might be a little bit better, other than when there's an effort to specifically try to identify a point of contact.
Awesome. Well, thank you so much for sharing. And just as a reminder to our audience, if you have any questions, feel free to drop those in the chat or in the Q&A feature. We'll come back to your audience questions here in a little bit, but now we'll go ahead and kind of transition into a new topic. So we know that federal programs are designed with national goals in mind, but their impact really ultimately depends on how they connect with those rural communities on the ground. So across Kansas and beyond and other states, we hear that there's a wide range of experiences, with some communities having strong relationship with those federal partners, while maybe some others don't have as strong connections with those federal and even state partners. So with that kind of idea in mind on how do we really connect local up and how can the role as a federal government to reach those rural communities. First want to talk with Jody. When we think about that distance between federal systems and the day-to-day operations in rural communities, I think providers can feel that quite directly. From your experience working closely with those providers who must implement those federal programs while navigating some of the challenges we've talked about today, from workforce shortages and financial constraints, where do you see those disconnects between federal expectations and local realities, and what can help bridge some of those gaps?
I think probably the greatest challenge we've experienced in our federal awards that is somewhat uniquely rural is the ability to demonstrate outcomes against a control group. We're small populations with, limited ability to do that. And it's really difficult in a rural community when you care for everyone to segment the patients you care for to the haves or have-nots around a new intervention, et cetera. And so then we find ourselves trying to reach out to other communities who may not be implementing something like integrated behavioral health and try and figure out, will you share your data with us? And they're so resource limited. They say, we would be willing to, but we don't have the manpower to do it, and et cetera. So sometimes I think our greatest challenge is, as there's been understandably more and more push at the federal level to really be able to demonstrate the effectiveness of your project and the impact it's having on outcomes, to really, just recognize that we have small denominators when we do those sorts of calculations. I remember as CEO of Labette Health, on occasion, some of the things we were asked to report, we were either perfect or we were poor. There was nothing in between because our denominator was so small. And so it's those sorts of pieces that some of our project officers and our assigned TAs, et cetera, who've been with the programs for years and really understand the challenges of rural, they really get that. And sometimes folks who are coming over from, public health sectors, research, et cetera, and are fairly new to rural may not quite yet understand sort of the realities that we live in and the limitations that we have just due to our small populations. And so I think that is one of those barriers that, as these rural specific programs are rolled out, and I fully understand the goal of wanting to be able to demonstrate outcomes, but that is, just one of the inherent problems we have as rural grantees.
Absolutely. So, Diane, you talked quite a bit in the beginning of our conversation today about with the rural public health strategic plan, a large part of that being building those connections with rural communities and rural partners. So I'd be interested to hear how CDC is kind of operationalizing that strategic plan to build those stronger, more accessible, and more consistent relationships with rural communities, particularly those who may feel a little bit more disconnected from the federal government.
Well, first, thanks, Jody, for mentioning that my office size is similar to yours, but we have to attend to the whole country. That does make it challenging, and we are small, but a few different things. First, I always tell my staff that some of the challenges in front of us are really big. But if we just say, oops, too big, too complex, and don't do anything, to me, that's a fail. If 20 years from now, we're still in the same place, that's a problem. So what I'm always asking my staff, how do we start to chip away at something? What's the first thing we need to know? Then what's the next thing we need to know? How can we incrementally get where we need to be? And you can do that in steps, but you have to figure out what the steps are. So a lot of our approach is basically show up, like actually go to rural communities and then actually listen and listen for understanding, not listen for the next thing you're going to say. And then provide what I call helpful help. I've been saying that for years. People ask me initially, isn't that like, shouldn't all help be helpful? And then I follow up and say, hey, have you ever been on the receiving end of unhelpful help? And most people have. So the idea behind helpful help is if you've shown up and you've really listened and set aside your agenda and idea that you're the expert with all the answers, you can probably find a way to provide some helpful help. I never assume I know the answer. I'm sitting here in Atlanta. How could I possibly know what the answer is for a rural community in Kansas? I need to show up, look around, talk to people, try to understand things, and then see what I can offer. I don't have all the answers. I mentioned that we are in a position of influence and connection with other parts of the agency. That means doing a lot of consultation, working with staff that are doing outbreak response. But a couple of specific things, and this gets back a little bit to the idea of flexible funding. During the pandemic, CDC, for the first time ever, did have a funding announcement that included a rural carve out. And we worked with Tom's office on this. And this was the first time CDC ever said, hey, states, guess what? This is how much money we need to see go to rural areas based on a population formula. And oh, the second thing is you have to work with your state office of rural health. This is the first time we've ever done that. And so we are evaluating that because we think that is critically important. And we continue to emphasize the importance of that sustainable, flexible funding. I can't dictate how things need to go or what the issue is or things like that. The second thing is, one of the things I've heard loud and clear over the last few years is that trickle-down communication and trickle-down funding doesn't work. It's easy sitting at the federal level to say, well, we're just going to work with the 50 states, and then hopefully we're working with tribes too, and then hopefully we're working with, territories and freely associated states. But that makes it easier for us to sort of work that way. But things don't always trickle down from the state. Communication, money. So one of my goals, thinking about chipping away at things, is how do I develop a network where rural communities have a way to connect with my office intentionally, strategically, systematically? What does that look like? And it doesn't need to be like, I don't want to do bylaws. I don't want officers. I don't want to do any of that stuff. I want to set up something where we can have real conversations because this helps me be smarter in my work. I know what's happening on the ground. I can bring those stories back to my colleagues at the agency. I learn about strengths and a lot of times can elevate those. One of my favorite questions that I asked during the pandemic was, are there any rural communities that have vaccination rates that are higher than we might suspect? Which is a completely different way of looking at the data. And guess what? We did. And we funded a project to actually try to identify what it was those communities were doing. But it's a different question. It's a different way of looking at it. And I don't know that I would have thought to ask that question if I hadn't been showing up to rural communities and listening to rural communities. And I know that there are strengths out there. I get that. So how can I be a change catalyst here, basically, and start to ask different questions and start to say, hey, what about, like, could we do another rural carve out on some big funding announcement? What does that look like? I regularly tell people, I was like, sometimes we do things that let rural communities know we don't mean them. And so if you've got $5 million and you've decided to make 5 awards of $1 million each, you just let some rural communities know that they probably shouldn't apply because there's a capacity issue. There is such a thing as too much money. That might work in some areas, but not others. So yeah, I have an ask for all of you. I really want to get this communication network established. I don't know what that needs to look like. I know that I probably can't go through the state and say, hey, let me know who all your rural people are. I probably can't go through a national level partner either. If you've got an idea for me, please email me at ruralhealth@cdc.gov. I think this is going to be something that we gradually build over time because I can't listen and say, okay, in February, I'm launching this national network to talk to rural communities. I'm going to start where people are willing to engage with us, and then hopefully word of mouth will help it build. And honestly, I just covered so many things in that answer. I'm not even sure I answered the main part of your question. My apologies for that.
No, I think you did. And as we're thinking about the conversation today, it looks like Janelle has put that email in the chat. But if you have any ideas for Diane and Janelle, feel free to put those in the chat too. I'm sure they'd love to follow up with you. So before we transition to our next topic, Tom, hearing about Diane's comments on helpful help and really with your position being in FORP and having that be such a long-standing federal office at this point, what strategies have you seen that have been successful in making federal partners more accessible, visible, and responsive to rural communities? And maybe what are some of the strategies or the times that you've seen it not done as well? Hey, Tom, can you come off mute? Thank you.
I think that's a good question. I think Diane, I think laid out a great example. We thought the carve out was one of the most creative things we've seen in the 25 plus years I've been here. Um, block grants, I think, are a wonderful mechanism to reach larger population areas. I think it's a challenge sometimes when you are trying to get to the smallest of communities. Another thing that happened during the pandemic was we got travel specific money. And just like I talked before, that rural competing against rural was important. I think tribal competing against tribal because it's different. I mean, tribal entities are able to get our grants, but probably not at the success rate that perhaps other parts of rural do. And so, I just think that you always have to be open to trying a different approach and thinking of things differently. We never keep our funding notices the same because people are pretty vocal about what works and what doesn't. I think Jody laid out a great example of where we create structural barriers. Sometimes just with our evaluation thresholds, we create barriers because there's no way that some applicants are going to be able to have enough volume in their project to have sort of statistically reliable estimates of whether the grant has had an impact. And so I think the things that have not worked are well known in Legion, and that is, just thinking that one size fits all. I think in terms of what's worked well, I think the approach Diane laid out really works well. The other part is I think just re-examining our programs every couple of years, and then also realizing that perhaps what you start with in terms of intent is where you end. So I'll give you an example with our rural maternal obstetrics management strategies program. That's a mouthful. When we created it, I had in mind that we would help stabilize obstetric care in rural hospitals, but that wasn't who applied for the funding. Who applied for the funding were community-based organizations that were just trying to increase the number of women getting into prenatal care early, continuing it throughout, doing risk reduction, and also risk identification to get the more complex births to be handled at the appropriate level, and then handling those births that are appropriate at the local level. It's not the program I started with. It's not the program I envisioned, but it's the program that based on the reaction is what the communities wanted. So we've shifted it back towards that. And so I think the other part of it is just the feedback from the communities, and I think KHI can play a great role here. When we hear one example of why a grant doesn't work, it's important. We want to pass that on. But when an entire state can come in and say, hey, we applied for program X and here are the big barriers we were not able to leverage, that I can take that to elsewhere in the department. Diane can take that in CDC. And so, I think we want to hear from those situations in which maybe you saw a funding opportunity and you thought this is perfect for us, but then as you got into it, you realized it was not going to work. And then, when we have those examples and they're more than just anecdotes, I think that that gives us something to work with. This is always going to be a challenge. 80% of the population is in urban areas, and yet the 20% that's rural is spread across 80% of the land mass. And so it's never done intentionally. It's more done because of a lack of awareness. And so, hopefully if we can bring good examples to bear, we can make these programs as relevant for rural communities as they are for urban and suburban.
Thank you so much for sharing that. And I'm looking at the clock. We have about 10 minutes left. So I want to go back to Wyatt and see if we have an audience question.
Yeah, thanks, Shelby. Question about food as medicine. What efforts have you all been involved in that mention of food as medicine coming from Amy at a local coalition in Kansas? So, food as medicine, and maybe I'll direct it this time to Jody to start.
Thanks. The work we've done in food as medicine has been very preliminary, but it's primarily connecting with the leaders that we have in the state that have been piloting projects, like the team from Sunflower that have been working with a group of 6 FQHCs, and the Hunger Free Kansas initiative, and KDHE with their 100 farmers who are accepting farmers market food vouchers, and various sorts of things, and then connecting with other states like Fresh RX in Oklahoma and saying, how have you had impact in your state? Admittedly, in an urban area, they wanted to know from us, how do you expand something in across a rural state? And we wanted to know, how have you been successful in food as medicine? So there's been sort of those discussions, et cetera. Our goal is to come together in with all of those entities, and the concept of community health workers and partnering with research and extension, and really being able to deploy a food as medicine program across rural parts of the state of Kansas. So it's a really exciting vision for with a group of leaders who have, some of whom have experience in various components of working with primary care clinics and successfully implementing, and some with very specific food as medicine components. And then how do we engage our agricultural community that, let's be honest, primarily focuses on growing wheat and raising cattle and et cetera? And how do we, really engage around regenerative farming and produce? So there are a lot of components to the program. But it makes me go back to something actually that Tom told me years ago, and he probably doesn't remember this, but they had put together a report on how to support rural health clinics and rural and transitioning to rural FQHCs. And so I reached out to him and said, at the underlying, base, what's allowed these communities to do that? And he said, it's boiled down to leadership, Jody. The report gives examples, but at the end of the day, it's those leaders that are committed to moving something forward. And I think what we have assembled here in Kansas now is a group of leaders from different aspects and different areas of interest who want to come together and move something forward. And so I think from my perspective, what's most exciting about food as medicine is that leadership commitment.
Thanks, Jody. And we're going to do a couple more audience questions, rapid fire here, as you all have come up on the end of your time. I'm going to go first to the Q&A side. A question from Catherine at Kansas City University. I'd love to hear more about how creating a fundamental shift in how we fund primary care or prevention fits in. And maybe go to Tom first there.
Well, it's, how many years have we been talking about primary care needing to be the foundation of all care in rural communities? I go back to the managed care revolution in the 90s and the gatekeeper model, and it's always been the right answer. We just, for whatever reason, you gear up for it, and there are some small policy initiatives around it, and then it sort of fades away, just because there's so many competing interests in the healthcare system. But having said that, I agree with the premise of your question, and I think that it can link back to what Jody just said. Is like, how do we engage physician leaders in being part of these projects? I think about the some of the folks I've met through our grants that where the local doc gets involved really makes a difference. I think part of it is training more of them, so our residency programs are really important. But I think they have to be part of. They have the burden that urban doctors don't have. They have to not only be clinicians, they have to be local community development leaders as well. And so, how do we create opportunities for that? I do think the funding we have through our rural health outreach provides the opportunity for that because of the broad nature of it. And then part of it is we also need to probably build that into the curriculum, although everything we need to blend into the curriculum, it'd be 12 years by the time we're done. So that's the other challenge there. But it's not much of an answer in terms of specific asks, other than you're right. And we'd love to hear ideas on how to leverage our funding to do it.
Diane, I want you to jump in on that question, thinking about prevention side. Uh, and the other thing I'll flag, Anita, I see your hand raised. I think we're going to run out of time. If you could put your question in chat, that maybe gives our speakers a chance to follow up. But we're running up on our time. So Diane, prevention, how do we get that fundamental shift to prevention?
Tom's right. That is such an important question. And it feels like it's so obvious. I do think the competing interest piece is really important. I've been pointing to the now old reports from the Institute of Medicine when they were still called the Institute of Medicine that talked about the importance of prevention and the public health system and focusing on primary care. And looking through those reports, one from 88 and then the second from 2002, I think, it's kind of depressing because all of those opportunities are still there. And so I'm not sure what the answer is. Yeah, that's not very satisfying.
That's okay. I want to point out the last question, and then I'll turn it back to Shelby for you all to wrap up. Uh, Yvonne over in Maine, a question for Diane and Tom. Where do you see funding to support rural EMS going? Any hope of resurrecting the ET3 program?
Well, I'll start, and Diane, I'm sure can add or improve. And Jody probably can add and improve on both Diane and I. So, thanks, Yvonne. I've read about 10 of the transformation plans and been impressed by the number of plans that are integrating EMS into the discussion, including one state, I can't remember which. It might have been, I know Kansas did a great job on it, so I read Kansas' plan. Talked about creating a new Medicaid reimbursement mechanism where you would get paid even if you didn't transport. One of the big problems is you only get paid when you transport a patient. So if they could do a wellness check in there, kind of a variation on community paramedicine. So I do think we'll see some creative approaches in the transformation plans, and maybe that's a step toward it as well. As far as the ET3, with all due respect to my CMS colleagues, I think it was a good example of what Jody brought up earlier, in that it required a threshold of participation that really made it very difficult for rural to be meaningfully engaged, because you basically would have had to include all of the EMS providers in a low populated state. And then you have this far-flung network where you have higher fixed costs to actually do the services. And so I would love to see another version of that, but perhaps with lower participation thresholds.
So I will readily admit that when I hear someone mention EMS in rural, that little cynical part of my brain's like, uh-oh, what are we going to pile on? It's kind of like when we decide health education is really critical, so we're just going to pile it on to teachers. Oh, teachers will have time to teach all of these other things too, on top of, everything else that we've piled on. I think EMS is a critical function that needs more sustained support. I think there are some policy levers we should be paying attention to that could help EMS as a function, and CDC's done a little bit of that work. But it just feels like one of those things where there's not one easy answer. We have to come at it more comprehensively. We have to think about what is it we mean when we say EMS? What does it mean in terms of training, certifications, who's allowed to do what? How do we do an assessment of what the community needs? And then how do we figure out how to fund that in a way that makes sense? There was one, I think it was Arizona, that used some of our rural carve-out funding that did a study of their rural EMS. And they just made a couple of changes in how they handled calls and noticed improved efficiency. And I don't like talking about efficiency either, but honestly, if you've got a limited resource and you can figure out how to not deploy it if you don't need to in a way that keeps everybody safe, I think that's a good thing. So I feel like it's really complex. So it needs more funding, but I think it needs all those other things too. You know, a lot of times we say, well, throwing money at it won't help. And we're like, wait, what? How is that possible? I think it's because we need to be thinking about that larger context. We need to be thinking about regulations and training and capacity and policies and all those other kinds of things.
Awesome. Thank you so much. So we have 1 minute left. So we're going to do a rapid fire final question. So for all of you, based on your work with rural communities, partners, health systems, what is one practical step or message that you believe can meaningfully strengthen rural public health and healthcare capacity within the coming years? So let's go ahead and start with Tom. What do you think is one message or one practical step that can help?
I'll say two words, and one is the partnership aspect of it, which has been going on in rural forever, but everybody has more than one job, and it's hard, and yet there's never enough capacity, so you have to come together, whether it's an informal network or informal network, and then engagement with us, engagement with the executive branch, the legislature, clearly articulating the challenges you have, what works, and more importantly, and just as importantly, what doesn't.
Jody, on to you.
I think building on what Tom said, regional collaborations. We've had networks here in Kansas since the original critical access hospital days, but really focused, intentional regional collaborations, I think, are the key, so that we're really figuring out how can two or three of us together address a gap that not any one of us can, like reestablishing OB services, that we really can explore that, and setting aside the histories in order to figure out how to make that happen.
Awesome. And then Diane?
I'm going to third that, but get a little more specific. I think prioritize community partnership building. I sometimes call this the old school Sesame Street approach. Remember when Bob was singing about who are the people in your neighborhood? That's what we need to be thinking about. Don't just stay in with the usual people that are talking about health. What about the postal carrier? What about the mayor? What about the health people, the faith leaders, all of those folks? One of the things we heard from some rural areas during the pandemic was that faith leaders and providers felt they couldn't talk about some things because they were concerned about patients not coming back or members of a congregation not coming back. And so they were weighing things longer term. And they felt really alone, and didn't really have anyone else to connect with. But if you're talking with the retail folks and the mayor and everybody else, some of the best successes, I mentioned the question about the rural areas that had the higher vaccination rates. What we saw in those areas were different groups were coming together. It was the sheriff, it was a judge, it was teachers, everyone coming together, talking about what can we do in our community that is going to help. So I think Sesame Street got it right all those years ago, and so many community groups say we're stronger together, and I think it's absolutely true. We've got to get out of those sectors.
Absolutely. I love that. And just thinking about one of the major strengths of rural communities is that sense of connectiveness and sense of community. So thank you for bringing that to our attention. I want to thank all of you for your participation today. I probably could have listened to you all talk for 3 hours, the entire event, but I just deeply appreciate all of your insights. And we'll go ahead and give them a virtual round of applause for all of their insights and comments, and we'll head to our 5 minute break. So we'll be back here at 11:49 with our next panel.
Well, welcome back, everyone. I hope you got a chance to stretch your legs, refresh water, and happy you're still here for our second panel. So we just heard a really great discussion about federal and governmental funding for rural health. And thanks again for all of our panelists and Shelby facilitating that conversation. Now we're going to shift to thinking about non-governmental funding. And we're really going to lean into the role of philanthropy in supporting rural health. So for the next 65 minutes or so, we're going to be joined by four stellar panelists to talk us through the ways philanthropy can support rural health. And I'm going to introduce them now, starting with Jessica Hunt. And as I introduce each of you, can you just come off mute and say hello? Make sure our mics are working. So Jessica Hunt is Vice President of Strategy and Programs for the Patterson Family Foundation. Her career began at the Cerner Corporation, where she spent nearly a decade leading lots of different efforts. She's got expertise at the intersection of technology, community engagement, and scaling solutions to improve healthcare access and outcomes. She joined Patterson Family Foundation in 2019 and has been Vice President of Strategy and Programs since 2020. In her role, she advances the foundation's strategy and operations to achieve grant-making results, overseeing multi-million-dollar annual portfolio focused on economic opportunity, education, healthcare, and community engagement across Kansas and Western Missouri. Jessica, hello. Thanks for joining us.
Hello. Thank you so much for having me.
And our next panelist is David Jordan. David is the president and CEO at the United Methodist Health Ministry Fund, often referred to as the Health Fund. David, before joining the Health Fund, served as the executive director of the Alliance for Healthy Kansas, a coalition of more than 100 organizations working to improve access to healthcare in Kansas. He has more than 20 years of experience leading state and national efforts focused on changing policy to improve health and reduce disparities. We've had the pleasure to partner with David on several projects. And David, it's great to have you here.
Good morning. Thanks for having me, Wyatt. Look forward to the discussion.
Our next panelist is Ed O'Malley. Ed is president and CEO of the Kansas Health Foundation, which is tackling bold goals like raising Kansas's standing in America's health rankings. Before joining the Kansas Health Foundation, Ed was the founding president and CEO of the Kansas Leadership Center. He's also the author of several books, including Leading Health: How You and 30,000 Kansans Help Communities Thrive. Ed, happy to have you here.
Hey, thanks, Wyatt. Great to be here. Excited for the conversation.
And last, certainly not least, coming all the way virtually from North Carolina, is Alan Smart. Since 2017, Alan has served as a national spokesperson and advocate for improving philanthropic practice under his group, Philanthropy Works. You'll notice that the R is capitalized. It is capitalized for rural. And Alan has shared with me that he's semi-retired, but he's happy to be here, and we are happy to have him. And under Philanthropy Works, he's worked with individual funders, philanthropy support organizations, regional and national rural organizations, and national nonprofits on a wide range of strategy, writing, research, and coaching projects. Alan is also the former interim president, vice president of programs, and director of the healthcare division at the Kate B. Reynolds Charitable Trust, a $700 million statewide North Carolina funder. Alan, thank you for being here as well.
Thanks, Wyatt. Enjoyed our conversation the other day and love to be with these great folks on the panel.
Well, I'm really excited to have you all here, and there's so many places we could start this conversation. Uh, but I'd like to start with a question that is also one of those questions that maybe has many starting places. I want to talk about prioritization. The list of potential things that you all could support, that we all could collectively support with our philanthropic efforts in rural health and rural communities is really long. There's a lot of potential challenges, a lot of potential opportunities. And I imagine if we asked folks in chat uh, to come up with some issues or some opportunities or some challenges, everyone could identify a few. So there's not a shortage of potential things to think about. So Ed, I want to start with you. The Kansas Health Foundation has a three-part purpose, which includes that bold aspiration to empower Kansas to lead the nation in health. That's bold. And I think that in that bold vision, bold purpose includes rural communities. So when you think about that bold vision, you think about all the possible ways you could try to advance it. How are you all thinking about focusing the work you do and seeing rural in that work?
Yeah, Wyatt, thanks for the question. Excited to get the conversation going. Yeah, I appreciate you mentioning that first part of our purpose statement to help Kansas lead the nation in health, and we mean that literally. No state fell further in America's health rankings than Kansas the last 35 years, and we feel some culpability for that, and also want to do whatever we can to turn that around. But to answer your question, I got to mention the second part of that purpose statement, which is to eliminate the inequities that are creating health disparities. Like we know Kansas won't climb the health rankings just by helping healthy people get healthier. It's all about knocking down the barriers, knocking down the inequities that create the health disparities. And everybody on this Zoom knows that there are real inequities that exist in rural Kansas. And if we don't, so I think maybe the first thing I would say is we don't think we can climb the health rankings without a focus on rural. Like it just doesn't make sense. It'd be like the equivalent of saying we're going to climb the health rankings, but we're not going to focus on other populations that face tremendous inequities. Like it just wouldn't make any sense. So to us, it's just absolutely critical. It's why things like I love what David pointed out earlier in the chat that Medicaid and Medicare are such a huge percentage of the health spend in rural, which is one of the reasons why Medicaid expansion has been such a big focus of ours for a decade. So it's on our mind a lot. Just a few of the other things that we think about when it comes to how we prioritize rural. We have a lot of statewide partners, and I could rattle off their names, but they'd be familiar with most of the people on this Zoom. And what I've noticed is most of those statewide partners have a very clear and dedicated focus on rural. They get the importance of rural. Now, we have a lot of more localized partners too around the state, and some of those are more urban, some of those are more rural. But a lot of our partners are with statewide organizations that share the commitment to rural health that I think is present on this call. A number of other things that come to my mind when we've invested a lot of money in growing rural philanthropy over the last several decades, believing that the presence of rural grant making is critical to help communities improve their health. And maybe the last thing I want to say, just as we're getting the conversation going, is I do think something we think about a lot, something I think about a lot is how can we help be a bridge between rural and urban? How can we help our urban friends understand that their future success is also tied to us improving rural health and vice versa? I think that's a role we believe we can play at the Kansas Health Foundation and are proud to do so. But we're happy to share more as the conversation unfolds, but hopefully those thoughts why it gets some things started.
Yeah, thanks for being willing to bat lead off for us. And you mentioned David, I want to come over to you next. So you and Ed both are at organizations that have a statewide focus. It includes rural, but it also includes non-rural work. And I know you've been involved in policy related efforts in supporting research. How are toss that prioritization question to you. How are you all thinking about prioritizing among all these opportunities and ways that you could try to affect change that support rural communities?
Well, thanks for the question. I think this will be a great discussion. And I think some of the prioritization discussion happened on our last panel, just talking about strategic plans, and it's critical to have some focus. But I think taking a step back, it's really just important to recognize that there are a number of health gaps and a number of funding gaps that rural Kansas and rural America faces. And philanthropy cannot fill the gaps that exist or the gaps that will be exacerbated by cuts that are going to be implemented in the next several years. Take for instance, food insecurity in SNAP. We know that SNAP funding was delayed for a bit of time at the beginning of November due to the government shutdown. And it really underscored the piece that for folks that are food insecure, and for every 10 meals provided to food insecure families across the country, 9 are provided by SNAP and 1 is provided by the charitable food system, of which philanthropy is just a part of. So at the end of the day, we need to be realistic about the role that philanthropy can play and the impact we have, which underscores why it's so important for us to be strategic as we think about filling gaps in rural communities. And I don't even want to say filling gaps. I think it's working in partnerships with the great organizations, many of which are on this call, to have the most amount of impact to help us fulfill our mission of improving the health of all Kansans. Um, you know, we really, as a foundation, we're a relatively small health conversion foundation that funds statewide. We give out about $2 million a year. So we know that if we're going to make an impact, we need to change policies and systems to ensure that they benefit Kansans and Kansans living in rural communities. But I think Ed's point on we really need to make sure we're addressing inequities and disparities rings true for us as well. We want to make sure all Kansans have the ability to thrive and lead a healthy life. And many of the same challenges that exist in rural Kansas also exist in Wichita and Kansas City, Kansas, and throughout the entire state. We really do focus on our mission, which is to improve the health of Kansans, and then prioritize what we can do strategically based off of research. And that is, focusing on improving access to sustainable health care, and making investments to making sure all Kansas kids can thrive, and then really building engaged congregations recognizing our history, but communities, because we know that the more engaged communities are, the better policies and systems that they have, and the healthier those communities are. So we really have a number of tools in our toolbox to help us really fill gaps in rural communities and try to work on health. And, first and foremost, we want to fund programs that make a difference. So some of it depends on where the partners are that might be willing to partner with us. So, whether or not it's an evidence-based home visiting program or community health workers, we want to find partners that are willing to take some risks and say, does this intervention make a difference and improve health? We want to make sure we evaluate that program, but then really we want to make sure, to Jody's point earlier, that those programs and those investments can be sustainable over time. So it's investing in programs, testing the programs, seeing how to improve the programs, and then investing in that policy change to ensure there's financing to make it sustainable or to help go attract resources. Another way that we want to change systems is just by partnering with state agencies on administrative policy. Some may call it advocacy, but really there's a lot of opportunity to work with administrations on policies that can improve health. For instance, again, this is across the state. We know that a healthy start is critical for moms and babies, but how can we work with state agencies to make a difference to make sure, one, we expand access, doing things like making maternal depression screens, being able to be financed through well child visits for the uninsured population of new mothers, or extending postpartum coverage, or working with state agencies to establish payment policies that make community health workers and doulas an option for families living in rural communities, all of which will improve health. This is all done through partnerships and administrative advocacy. And oftentimes, again, tested by grantees working in the field. And then I think the other piece that we touched a lot on in this first part of this discussion is just recognizing that funding does play a key role in the ability to try out new programs in rural communities as well as to sustain programs. And Kansas as a whole does a bad job in bringing federal dollars back to the state, whether or not that's the percentage of federal funds making up our state budget or in our ability to sustain secure federal grants. So over the last several years, we really prioritized that and helped invest in providing technical assistance. So it's easier for rural communities in Kansas to apply for federal grants, and we've brought back over $70 million in funding for rural Kansas through that focus. So then it becomes again to the question, Jody, how do we sustain some of that? And that's why that administrative advocacy is so important. So at the end of the day, we prioritize in some ways based off of needs, some based on groups on the ground that are willing to partner with us, but we want to make sure that we can be partners with group to make the biggest impact in changing policies and systems strategically. So look forward to discussing more.
Yeah, I heard so many things in there that I know we're going to come back to, and words that are little flags in my head. A question of risk, and I heard the word engagement and partnership. And Jessica, I'm going to come to you next. We're going to stick with our Kansas folks first, and then Alan, don't worry, I'm coming to you right after. Think about the Patterson Family Foundation. You all have an explicit rural focus, but that rural focus includes healthcare, but also includes education and economic opportunity. But that fourth pillar is what I'm really curious about, because I think it is maybe a good build on what David said. It's community engagement. So tell me a little bit about how you all are thinking about prioritization and what role that community engagement plays and how you're practically doing that.
Yeah, great questions. I'm so excited for the conversation here today. And community engagement is one of our newer areas of focus. We had been explicitly for the past 5 years focused on healthcare, education, and economic opportunity as part of our donor intent, the direction that our board and our founders wanted us to go as an organization, with that explicit focus in rural communities, because we've all seen the statistics out there that only 7% of philanthropy makes it back into rural communities. And so our intention is to, put our philanthropic spend back in rural communities, and also, work with the funders on this call, work with the state partners, work with the national partners to bring more dollars into those communities. And part of the bedrock in being able to do so is ensuring that communities are engaged, that they are taking control of their destiny, and they've got the capacity and the resources to do that. So early on in a lot of my work, I was boots on the ground in rural communities, helping develop programs, helping build consensus, helping come to solutions on really tough problems. And the one thing that we always run up against is, do we have the right leaders in place? Do we have the right voices at the table? Who are we missing? And so this year, we were really excited to add community engagement as a core area of focus. And when we think about community engagement, again, it goes back to those leaders, but we don't define leaders as only those civic positions or those board representatives that are serving on your hospital board or serving on your local community foundation board. We view leaders as anyone in the community who wants to take an active role in helping define the local identity, preserve what's really important from a culture perspective in communities. We heard some conversation earlier from Jody and from Diane about understanding that local context and supporting that, and really coming in to lift that and build strategies around what's already in existence from an assets perspective, we want to be really respectful of that. We don't want to be seen as the funder that's coming in with our money and with our programs telling communities what to do, because that's not successful, it's not helpful help, and it's not sustainable. So as we think about community engagement and local level leadership, it's how can we add value so that good things happen in that local context, and how do we provide that flyover coverage, either in terms of funding, in terms of networking, in terms of our voice or advocacy that we can put back out into the world to help solve these real world problems, and then right size that back into the rural context. Because I loved Diane's comment earlier around rural is not small urban. And we need to be really mindful of that as we're right sizing and scaling solutions for some of the opportunities that we have.
There's a word in there, leadership. Ed, I'm coming back to you after I let Alan jump in here because I we have to circle back to that word leadership. But Alan, I'm not going to ask you to talk about your prioritization because you sit in a different spot. But I think about the challenge of what do we focus on? And I think about something David said earlier and mentioned risk, being creative, being innovative. When I think about both of those, one of the ways that can come together in my mind is thinking about who we fund and support. And Jessica mentioned there are people that might not have that title or might not sit in that official seat, but are people that are leading this work. And I wonder if sometimes we can miss out on transformative work because we miss supporting the people or the individuals or the organizations that can do it because they don't quite fit the mold or the requirements. So thinking about all your experience talking with foundations across the country, working as in a foundation, how have you seen funders think about who they fund and support and how that shapes what they're trying to accomplish?
That's a 2-hour workshop I give, so we'll consolidate into a couple of minutes. So I know you have 6 questions. You prepped me for 6 questions. Yeah, I think this is one of the most critical inefficiencies or parts of the ineffectiveness of a lot of rural funding is funders continually end up funding the wrong people. And they end up funding the wrong people because they're used to funding often urban organizations that have a perfect audit and a staff of 200 and can speak to a funder like funders like to be spoken to. And so when you get past that, then, okay, we're looking for fundable groups or people to work with in a rural county or parish. And there's often 1 or 2 groups that raise their hand, and they look kind of like an urban group. They seem a little more sophisticated, a little more together. They've had funds from federal side and different foundations, and they often become the favored sons and daughters of funders because they're easy to fund and they're going to send in a great report and they will say all the right things, and you can put them on the website where they brag on how great X foundation is. And I'd love to say that doesn't exist, but particularly in the rural work, it really exists. That funders continually are funding the wrong people and ignoring where the real energy is and where the non-title leadership is in service to board concerns about fiscal sustainability and measurement and return on investment. None of which may be particularly germane or important to anyone actually living at these places. So, imposing the funder template, board sanctioned or program officers as they have been trained, it's often very counterproductive. And the notion of risk, comes in a lot of different ways. But when I teach these things, I have kind of a 4 square, high risk, high reward, low risk, low reward. So much of the rural funding I've seen, even unfortunately some I've been involved in a leadership role, is what I would call low risk, low reward. And yeah, there will be predictable activity, and no one will feel particularly good about it in the rural place, and things will stay the same, and you have sanctioned the same gatekeepers, you know, I'll use this term advisedly, puppets of landowners and those who own the economic models, and things continue on. So yeah, to be an effective rural funder, you've got to really shift your mindset and have a different ideas about risk, and also consider where people have energy, and it's not pitting the dental people against the mental health people against the early childhood people. It's getting a sense of where people think they might be successful. And some of that involves, I think, supporting, think it was in the first panel, it was Diane, maybe, talking about, yeah, where have there been effective kind of regional efforts? And regional might, in some states, regional might be just within the county. In Louisiana, I lived deep in the woods in rural Louisiana for a decade, and the historic animosity between those in one part of the parish and the other part of the parish was profound. But there were always examples. Sometimes they were forced, sometimes, just there was urgency, where they had worked together in really meaningful ways. So, look at what's been successful, even in the poorest places in the country, and, use that as kind of at least a baseline or a place to ground yourself. But the idea of prioritization in places with very few resources, which most rural places have, accepting some of the retiree communities, the idea of pitting people against each other because they are more needy on the health side is really, at a very human level, just very unkind and destructive. But I think there's clues, and some of them are in plain sight, that funders choose to miss because they need to serve their model of who gets funded and how they get funded and when and how the reports are done, and making sure the ex-troublesome board member doesn't ask the questions. So it takes some serious work to do this well, and it's not my consulting logo is not just more but better. That it takes some serious intentionality to do this well, and it's not just writing a bigger check.
There's so many jumping off points. Thanks, Alan, and thank you all for sort of setting the stage for the rest of this panel. I want to remind people, if something's resonating with you, if you've got a question, add that to chat, add that to the Q&A. I want to come back to risk, and Ed, I'm gonna go to you, because I think every foundation has probably thinks about risk on some level, and I'm looking forward to hearing others think about risk. But you all identify risk pretty intentionally, and you have a statement on change, and that includes 10 aspects, and one of those is simply titled "Take Risks." Take risks. So, how are you thinking about risk and experimentation? How does that fit into this work?
Yeah, well, first of all, I love the question right on the heels of Alan's great comments. So, Alan, thanks for the provocative ideas you shared. And I think, I mean, foundations are just like everybody else, right? We're just like any other organization. All of us have people that we report to. We have authorizers. We're judged by people. And the safest thing to do is to like just do what people expect you to do. Like that's what's safe. And if you do that, you will likely never receive extreme criticism. You also will likely rarely achieve extreme impact. But like you can be good. You can like have a really nice life. And that's not just for foundations, it's for all of us. I mean, I learned that eons ago when I was in elected office, that the safest path, safest, if what you want to do is get reelected, is to not take many risks. And we criticize politicians for that all the time. But I actually think most humans are that same way. We tried subconsciously, usually we're figuring out like, how do I need to exist in a way that keeps those who control my authorization happy? And I get that on a human dynamic. And I think the foundations, especially endowed foundations, because of the situation we're in, because we're in this incredibly blessed, fortunate, privileged situation of literally we are unable to go out of business, right? I mean, if we don't lean into more risk, who the heck do we think can? And I've actually, with all due respect to any tenured professors and any other foundation people, with my colleagues here included, I found like the most risk adverse professionals I've worked with over my 25 years are in tenured professors and foundation executives. And I think like both of those groups are in situations where it's so comfortable. Like it is so comfortable. And I mean, I love, Jessica and David. I think they embody leaning into risk. I think there's more of that happening in the foundation world in the recent years. But to me, what it means is we have to understand that the little health clinic out in rural Kansas probably can't try something super risky. Maybe we could put up dollars for that risky experiment. And if it totally fails, it's on us. And you know what? We're going to be okay. But let's not expect them to shoulder that risk. So to me, like risk, it's just critical. Alan was talking about the folks we usually fund. We took a risk. We're funding 30 small grassroots efforts. We made a 10-year commitment to each of them, $1 million each. These are mainly organizations that, struggle to fill out their 990s. I mean, they don't have all the capacity, that Alan was talking about. And you know what? It felt risky and it feels risky because we don't have the beautiful reports coming back that we can easily point to. And we're having to kind of coach our board to, let's hang in there. These organizations, they're on the cusp of something. And it's putting pressure on us also to help them kind of reach those next levels of capacity. So I feel like I've shifted from being a panelist to being a preacher, but I think this idea of taking on more risk is critical. I think it's one of the roles of philanthropy. And I love what David said. Like philanthropy can't fill the gaps. None of us have enough money to fill the gaps. So what we can do are things like make it a little less risky to try an experiment. Like we can do that. We can't fund SNAP, but we can fund things that might be risky for a food pantry to do on their own. So I think risk is critical, and I know we'll talk about leadership later, I imagine, but I think risk and leadership go hand in hand. And one of the reasons why those regional partnerships, those regional collaborations don't happen, we all want them to happen, but I think one of the reasons they don't is they feel quite risky to people. And nobody talks about that, but the risk involved is what keeps us kind of back in our box doing our thing. So more on that to come, but thanks for letting me preach, Wyatt. I appreciate it.
Yeah, David, you got several nods in there in Ed's response to my question about risk. Uh, Jump in there. How are you thinking about risk? You mentioned earlier pilot programs is one way. I think that's potentially part of this mix, but expand a little bit about how you all are thinking about risk and innovation.
Well, I mean, I think just it starts with and I think Ed and Alan touched on this already, but I mean, I do think there's a mindset that needs to be consistent across the leadership of your board to your senior level staff to say we're going to embrace risk, right? I mean, I remember interviewing for the job and said, like, I'm not interested in batting 1,000. Like, if we go 3 for 10, but the 3 for 10 are three, like a double, a triple, and a home run, we're going to be doing pretty well and have more impact. So I think you need to make sure you build a team starting at the governance level through the organization that's willing to say, like, we're not interested in like singles and pinch hits, like, in bunting to get to first base. So I think it starts with like defining that in your organizational culture. The way we look at it is certainly like looking, I mean, we do want things to be grounded in evidence, but I think everything is like, what can we do to see how we disrupt the status quo, how we disrupt maybe how services are delivered so that it can be better oriented to people on the ground. It doesn't mean going in blindly. It just means going in and being willing to be flexible, being willing to partner with organizations is like, oh, the implementing this manualized program may not work for rural Kansas. How do we adjust it and then adjust the evaluation so that it can work? And I think that's really how we approach it. One, pilot programs, approach it by being flexible and approach it by like strategic learning versus like we have to report back to the board that everything was perfect. Nothing's ever perfect. Like people that are implementing things on a day-to-day basis on this call know that like it's not like as perfect as the sales pitch sounds. And we want staff that ask the tough questions.
Oh, we might have had David freeze there. Uh, Comment in chat from Rodney about it. It is a delicate balance, assuming risk, and gave the example of a new healthcare service line, uh, maybe responding to a request from a rural community, but balancing that with making sure it can be sustainable and you don't want to go broke. And what I'm hearing is philanthropy has an ability to take on some of that risk in ways that maybe an individual healthcare organization can't. But that risk taking needs to be really thoughtful and intentional. And one of the comments you mentioned there, David, is about evidence. And evidence is something that we love at KHI. Quite frankly, we love evidence and data and supporting informed programs and policymaking. We've collaborated with you, David, to do work to generate good evidence to inform that policymaking and program making. And I think there are some times when we think about doing programs in rural communities, sometimes there's an element of going to a place or a setting or working with a partner where there isn't perfect evidence available to know that it will work. So how do you navigate that space where you're going into working in maybe adapting a program that worked really well in an urban place, but it's different in rural? How do you balance that dynamic?
I mean, I think research, if you ask me, I think we still do take a lot of risks as an organization, but one of the biggest surprises sort of during my tenure is the amount of research as a small foundation that we do. I think it's really, as a starting point, we talked a little bit of discussion on mobile integrated health and community paramedicine, and we partnered with KHI on that. We wanted to know lessons learned from other states. It wasn't because we were afraid to invest in something, and partnering with the Patterson Foundation, Family Foundation, and that's been a great partnership as well. But it was like understanding what's worked, what hasn't worked, understanding like some efforts in Kansas have failed before, which Dr. Mosher and Jody can talk about. But we don't want that to color our approach. We want to like integrate learnings into the program because we know that we need to change how we're delivering care and that mobile integrated health and community paramedicine can help us do it. It's been proven in other states, but it's going to take some work here. So whether or not it's working with grantees or healthcare providers that are worried about risk, like in the comment, or state agencies, like I think part of it is also, and it goes to some of Ed's comments, like how can we like reduce the risk they feel? How do we reduce every single possible reason for partners to say no? And that's a really important role that foundations can play in order to seed innovation, and help others take risks, like create that permission structure. But research is really important to helping people feel comfortable saying, we'll take that on, knowing that in Potosi, Missouri, in a really rural community, community paramedics have drastically reduced emergency room visits and hospital readmissions and help patients better manage their diabetes. Like there's no reason we can't do that in Kansas too, but we need that research base that KHI is able to provide to help EMS providers, the state, academics understand like, oh, we can translate this to Kansas.
Yeah, thanks for talking about some of that balance, and something that it makes me think about is maybe it's a false separation of either supporting doing the work or supporting the research and generating evidence. And maybe there's space to do both, and foundations can find ways to fund pilot programs, but also take on some of the burden of evaluation and collaborating with others to study how well it works and pull those findings out. So Jessica, maybe bring you in on that, because David mentioned your collaboration on that program. How are you thinking about maybe doing some of both of those at the same time, and how do you do that, and how are rural leaders that are doing this work responding to that maybe push to collect data to make sure we can evaluate, but wanting to make sure they have the space to really fund the work they're trying to do?
Right. Yeah, thanks for that question. Really enjoyed the partnership with David and his team on this mobile integrated health pilot. And kind of going back to the overall risk discussion first, though, before I dive into that, is from our standpoint, and we've touched on it a little bit in the conversation, but it's really important that we are pairing that risk taking with that learning and transparency. So whether that's feeling confident in taking the risk because you have data, or also feeling confident in taking that risk because there's not good data. I think Jody mentioned earlier on sample size in rural, sometimes you just don't have the right information. And we very much view that as our role in if we're going to try something new, let's make sure that we're intentionally designing what those feedback loops are and removing the barriers to do so successfully. So the MIH pilot's a great example of that, where we've come in with United Methodist Health Ministry Fund, and we're funding the expansion of these MIH sites. So we're working on getting new sites set up in rural counties on both the Missouri and the Kansas side. But we're also, David's come in and his team's done a great job of helping fund the research. So what metrics are we looking for? How do we make this appetizing for funders, either government or other funders like us, to come in and help scale this type of effort? But part of what we've done at Patterson is, we remain flexible in thinking about, hey, we put funding out here for this initial pilot program. Let's stay in touch. What are we missing as we go work on this together? How are we providing that additional layer of support? How are we being flexible but firm in the funding so that we're not, if a need arises, for example, we need better technology systems to make sure that all of these sites are connected, let us help you fund that. And then let's figure out what the sustainability model looks like later on. So that's absolutely part of that work in trying to evaluate with other partners. But part of this work in MIH is also, how are we leveraging our internal business intelligence team? So this is a new arm that we are standing up at Patterson, because we know that you can't really have data without stories, but you can't have stories without data either. And so how, in this case, for example, for MIH, can we engage our team to add some additional support in looking at, once we're getting information rolling in from those medical records, to understand what's going well with these pilot sites, have them do the evaluation. How are we bringing those resources? How are we asking our team to help document some of those risks, some of the reporting, and actually develop the case study with all of these partners, so that we are allowing the EMS providers to do the work that they do best, which is seeing patients. So when I think about risk and when I think about innovation, I don't think as a funder, this is a topic where you can say, here's your money. We are, giving you this big check to help remove the risk, and we're going to back out and disengage. And we've done our part. I think, a big part of our mission statement is working together to help communities thrive. And we truly mean that. So how are we showing up? How are we providing more than just the check, and providing some wraparound support services of Do you have what you need? Where do we need to be flexible in funding? Things change, projects change, you hit new barriers as you go. So how are we staying engaged enough and involved enough to know what's happening and have the foresight to help continue that blocking and tackling within these types of initiatives?
Yeah, and I appreciate the comment from Christina in chat as well about engaging trusted CBOs and faith-based organizations in some of that work for data collection, implementation, and that need to consider that broader context in which people live, and that aligns with some of what you just shared, Jessica. You all talked about collaboration from the side of two philanthropies, but I want to talk about collaboration among those implementing the work and among those communities that could share this work, and folks that have come to some of our events know that I'm from a small town called Ness City, and there's several other small nearby towns, but one of them is about 30 minutes away, and it's called La Crosse. And I know there are great people in La Crosse that love their community and want to make it healthier in the same way that people from Ness City do. But quite honestly, I still have a hard time not seeing La Crosse as a competitor. You know, we competed on the basketball court, the football field, the track, Scholars Bowl table, everywhere. Like it's hard for me not to see blue as in opposition to black and gold. And I think sometimes that good competition can bleed into unhealthy competition in some ways when it comes to this work. And we maybe have this perception that both communities can't win. Like I have to win at the expense of them. And Alan, I don't think you have a Nest City in North Carolina. You can correct me if I'm wrong, but I imagine you've seen some of this dynamic. So how do you think about supporting healthy collaboration or healthy competition and collaboration that supports some of this work that maybe allows us to accomplish things that we couldn't do if it was just one community working on its own?
Yeah, this is maybe some of the secret sauce of how philanthropy can be effective or support impact and support people's concerns. And the opposite of what you're describing, this kind of healthy collaborative environment that philanthropy wants to promote is something that funders do, which is kind of artificially make people work together. That might be across counties, within counties, different neighborhoods, people who either from historic reasons or just kind of cultural reasons. In the South, certainly some of that has, a racial element to it in the Southwest. But yeah, the collaborative piece, I think, works when funders are supporting people who either have some history of working together and they respect each other, or you're trying something new that people haven't even really thought about. But the collaborative models that are, forcing people into, and seemingly, if there's a 5-county model a funder wants to fund, there's one county that does not feel part of that. Because historically they just haven't. They gravitate to a different urban area, they have different people there, they settle differently. So I think the funder assessment analysis is it's on funders to learn how people relate to each other and where they work. For example, there are rural counties in the United States, and it's state dependent. 80 or 90% of the people leave the county to go work in an urban area. They drive 50 or 75 miles. And, how do those relationships impact these collaboratives? So I know Ed mentioned this, funder is a bridge between what are now naturally occurring urban-rural configurations. Funders sometimes are just funding the rural piece and negating, the assets of the urban. or how where people do get their health care, or where they drop their kids off halfway to their job 30 miles away so they could go to the better high school. And so there's got to be a level of due diligence that respects, these high school sports competitive things that have gone for generations, but also really looks for positives. And I think by asking better questions, funders can often find those positives in ways sometimes that local people can't, because they do see that community 10 miles away as the competition. But there's 3 communities in the next county that maybe they did something important with around, sustaining the rural airport or something, and we don't know enough often to make effective collaborative decisions on behalf of others. And so there's that's time, that's attention, that's listening better. I've seen so many examples. I'm very optimistic about that. That funders can actually help collaborative work, but it's not by taking a map saying these 2 towns or these 2 counties could work together.
Yeah, Jessica, share the example that David prompted in chat, and maybe that builds on exactly what Alan was sharing there.
Yeah, David, thank you for teeing me up. This project, I think folks on the call might be familiar with the Patterson Health Center down in South Central Kansas in Harper County. So our founder, Neil Patterson, their family has deep roots in that community, in that area of the world. And on Neil's bucket list, one of his top 100 things that he wanted to do before he passed away was to figure out how to help healthcare in his home community. And so at my time at Cerner, I was one of the only team members that had any boots on the ground experience working directly in rural communities. Jody had used the term living lab earlier, which made me chuckle because living labs were my very work at Cerner for 8 years of my time there. And the first living lab was in a rural community in Nevada, Missouri, and it was all focused on how do we develop programming around healthy food access, on health outcomes, on creating better pathways to care, creating environments that made the healthy choice the easy choice. And so I had 4 years of working directly in the community, understanding the business relationships, understanding the history, both good and challenging, and what made rural communities so special. And so when Neil approached our team back in 2014 to start this work with with what's now the Patterson Health Center, his ask to us was, hey, go meet with these 2 communities. There are 2 critical access hospitals in the county, population a little under 6,000, and they're 9 miles apart from each other. So what can we do to facilitate a better outcome in the future? Because this, of course, was during the rural hospital closure crisis that we still see happening today, but was really prominent in this time. And we were hearing lots about hospitals closing and what were we going to do about this? And so in 2014, I entered Harper County with Via Christi Health, which is now Ascension, and we facilitated a discussion with 2 hospital boards, Anthony Medical Center and Harper Hospital. And it was really centered around how do we remove the risk of you all collaborating? Because there are a couple of different things at play here. You've got two hospitals that are competing for the same patients, that are competing for the same staff. And there's deep community pride in both facilities. And there's a deep history of these communities being competitive that, as I learned in that meeting, dated back to the battle for who was going to be the county seat. And so walking in and learning and respecting what that culture was and understanding there's deep-seated pride here, and how do we leverage that? And when we talk about going back to the risk conversation, one of the things that I don't know is very publicly known is that Neil wrote Anthony Medical Center a letter because they were in the middle of a campaign to expand their emergency department, and they had $800,000 on the table at risk if they stopped to explore this project and this initiative. And Neil offered to make them whole if this didn't work out. But the challenge was, let's explore it. And so for 4 years, we worked together. We formed work groups. We had representatives from both hospital boards. I had lots of community members who were well respected helping navigate this process. And I provided project management support and really the resources to do the types of analysis that was necessary to understand what is a feasible choice here, and how do we take the mathematics and marry that with what the community wants. And so it was a year of study around what it does future financial sustainability look like in multiple scenarios. Is it both hospitals close and we create something net new? Is it one hospital closes and we make sure the other is updated and everything's looking great? Is it we do a shared service model? So this wasn't that what this project was not was, hey, we've got a solution. It was, we're going to get some outside help from the brightest minds in healthcare at the time to understand what the data is telling us. But we're also going to hold the community town halls and understand, what are you worried about? What are you concerned about? And in that process alone, just with the analysis, took a whole year. And it was a year of the conversations. It was a year of the representatives from both boards having the tough conversations and navigating having to show up at church on a Sunday, or go to the beauty shop on Saturday, or go to the local coffee shop and hear all of these different thoughts and opinions. In some cases, really supportive, and other cases, really contentious. And so I think, Alan, to your point around understanding and meeting communities where they're at, I think that project taught me the most. And those are lessons that we continue to embody and embrace here at the foundation. And so again, that together piece with the community is so important, because who are we to come tell a community what they need? That's not our place. That's arrogant. And at the end of the day, projects, initiatives change. We are a philanthropy. We do want to make the grants, but we really view ourselves as enabling change and change makers, which is a completely different way to tackle problems. And so if you want sustainable change, if you want things to build things that are going to last, you have to do it in a way that it's the community leading that transformation, and you're providing that support and blocking and tackling. So unfortunately, Neil didn't get to live long enough to see the new Patterson Health Center, but the result was we put that right across the street from the high school down in Harper County, because it was centrally located between the towns. It is, the high school had consolidated back in the 70s. And so that was considered, neutral turf. And there are great partnerships between the hospital and the school now. There are high school students that are working at the hospital that are getting those health professional laddering certifications to start their healthcare careers. So it's a great success story. Certainly, all rural hospitals are facing similar challenges, and of course, Patterson Health Center is as well. But I think it's a great and compelling story of, you can right size a facility to go from 50 beds in a community down to 16 to help future proof for those concerns around funding streams in the future.
Thanks for that great example. I'm want to flag time where we never have as much time as you'd like, and we're coming up on the end of our time together. I'm going to come back to you all and ask about some of the things that shape work outside of the money itself, the grant itself, and I want to touch on the leadership aspects. But I want to go to the chat. And Shelby, I think we have a question there from Jody.
Yes. So Jody's question is, rural organizations are requesting neutral third-party assistance in developing regional collaborations. How can foundations assist in this role?
Wyatt, I'd love to take a stab at that one, if that's all right. I think it's key. By the way, I can't speak for all the foundations, but that's a pretty easy thing to probably ask for money for. And I mean, there are some really good, objective, neutral, third-party facilitators in our state. And if you want one of the good ones, you need to spend a little money on it. But oh my gosh, is it such an obvious best practice? And it makes all the difference. And I think that's a I can't imagine a foundation in Kansas that wouldn't be excited to fund that type of capacity building work. And even just, I mean, some of us that we have a group of foundations that have been working on food and hunger issues. Uh, we've hired, an objective, neutral, third-party facilitator to facilitate our collaboration discovery meetings, and it's made all the difference. So, great question, Jody. I would just encourage people who are interested in that to reach out. You don't have to even know who the neutral facilitator might be. I think all of us, Jessica, David, myself, we all know them and they're good. And KHI knows them too, but it's a great idea. And it's an example of often the more authority somebody has, the less they feel like they're supposed to need extra outside help. But it's such a best practice to have neutral third party facilitators when you're trying to do something you've never done before. So love the question, Jody.
Yeah, I would just add I've actually done a lot of that funding when I had my foundation hat on, and the minor caution. So once one plan is done, or the neutral intermediary, then we saw a lot of, well, we're gonna do the exact same thing in the next region, and kind of dry the results to be kind of the same. So the individuality of the rural regions kind of get lost in the mix.
Well, yeah, Alan, they're no longer neutral in that
Yes,
situation. They
that's
actually
correct.
have an agenda. And so the key is for that facilitator not to have an agenda.
There you
Yeah,
go. Yeah.
what you're saying.
David, I know you responded in chat. Thanks for being so active. Do you want to just chime in on that question real quick before I circle us up for our final
Sure. I mean,
thoughts?
I think, as Ed said, I think, not to speak for other foundations, but I think all of the foundations want to make sure we can support these types of collaborations. And an example of something we've been working on for years that's certainly not one size fits all is just working with KHA to support conversations on the future of rural health. And KHF has partnered with us on that as well, providing funding to bring in the Public Management Center and KHA to be the experts and to facilitate discussions on, like, what does rural health look like in that community? Is it transitioning to a rural emergency hospital? Is it partnering between FQHCs? Is it partnering with CCBHCs? Is it, focusing on outreach and enrollment? So I think those conversations are going to be so individual, but it does help to have groups from the outside come in to help support those conversations. And I know that KHA is always looking for communities to invite us in, but being invited in is the key part of that project.
I I want to take us to leadership because we raised that early on, and we are short on time, but I feel like we need to touch on this because I think about that work to bring people together, the value of that external facilitator. But part of the question of long-term sustainability is building local capacity to exercise leadership, as Ed has taught us to say, not to just have leaders with the title, but those that are well positioned to exercise leadership. And so, Ed, I want you to jump in on that question, and I also want to flag in and tee up for you. I think one of the ways you're trying to facilitate us all thinking about our role in this and exercising leadership is with your new book, Leading Health, and the book on the website and in the materials has an invitation to every Kansan, and I think that invitation is inclusive of our rural communities, and that invitation is says whether you're an educator, business owner, faith leader, local official, health professional, or neighbor, health is already your work. And so thinking about that invitation and how we build leadership, how how important is that in this grand project we're all trying to do to support rural health?
Yeah, I think yeah, I think it's so important why, Diane said earlier in the first panel that we've got to get beyond the usual people that wake up every day and think about health. And we need the usual people to keep doing that. But if we don't draw in more people who don't get paid to think about health, but who actually are working on health all day long, whether they know it or not, if we don't draw in more people to care about the health of rural Kansas, I don't know how we turn this around. It's like it's too much to put on the backs of people who get paid to work in the quote unquote health field. And I think leadership is always about bringing more people together and helping more people see that they actually should care and do something. And they didn't realize that before. And I also think that the key about leadership is while there's so much out of our control, all the federal stuff, there's a lot in our control. And the beauty about trying to lean into how can we just help people get better at exercising leadership is when we do that, we can at least know we're going to make improvement on the things we can control. We can control whether La Crosse and Nest City collaborate, or we can influence that a lot more than we can influence what's happening in DC. And so the leadership stuff is stuff that we can own, we can influence and we can help people with. And I actually think when we focus there and we draw more people in, we're going to make more progress. The book, by the way, last thing I'll say is just the book is really just trying to be a big rallying cry that we need people who don't think they're connected to health to realize you're connected and we need you to do more and support those who are doing the work right now. So thanks for the question, Wyatt. It was a
Yeah.
small question for me, but I appreciate it. Thanks.
Final rapid fire. I want to give every person a chance, final thoughts or advice before we make sure people have the information they need for continuing education credits. Jessica, final advice, maybe thinking about those that are sitting in positions, hearing about this, wanting to seek funding. Final advice for those grant seekers, those looking for resources.
Mm-hmm. Yeah, I would say don't be afraid to reach out. Let's have a conversation. Tell us, pick up the phone, call us, email us, submit a form. We'd love to have a conversation with you and understand what you're up against, how we can provide support beyond the funding. So we just welcome the conversation.
David, final thoughts?
I guess maybe two things and two things that may sound conflicting. One, I do think we just need to recognize like the challenges that are coming down the pike with shifts in policy and cuts in funding, which is why it's so important to work together. But I think most importantly, I think how do we shift away from the scarcity mindset that we have so often in Kansas and in rural communities? We can accomplish a lot by working together and being creative. And I know that as foundations, we're here to support you. So let's stop looking at our deficits. Let's look at our strengths and let's look at ways that we can really change how we improve the health of Kansans.
Awesome. Alan, final recommendation, final advice, final word.
Yeah, to the nonprofit sector or those that are connected to that on the call, yeah, be intentional about including younger people and people newer to your communities in rural. I think from a funder perspective, that is really appealing because it doesn't happen often enough. So I am, when I was a funder and now that I consult, I'm always looking at efforts in rural that are intentional about including immigrants, whether that be, international or people moving from other states, people newer to community. And that's a signal to me there is energy and things can happen, that these are not gatekeepers and status quo folks.
Well, I want to thank you all so much for the time, for the thoughtfulness, for the discussion. I hope this is the beginning, not the end of our collective discussion and collaboration to improve this work, to have meaningful impact. And I just want to circle back to something that was said in the first panel, but I think is great sort of concluding thought as I turn it back to Rebecca. Diane said that they need, I heard 3 steps that are probably 3 steps we can all do. with our partners, with our rural communities. Show up, listen for understanding, and provide helpful help. I think those are three things we can all try to do with our partners, with the rural communities we're seeking to serve, and within our own organization. So thank you again for all your thoughts, all your wisdom, all your insights. Thanks for being here. And Rebecca, I'll turn it back over to you.
Thank you, Wyatt and Shelby, for moderating today's panels. They were fantastic discussions, so informational, helpful, and inspirational. And a really big thank you to our panelists, Diane, Tom, Jody, Jessica, David, Ed, and Alan. We really appreciate you spending your time here with us today and sharing your expertise and insights. And of course, a big thank you to all of our attendees who have engaged in the conversation and been here reflecting and listening and learning along with us. These events are designed for you, for our community, so we want to make sure we continue doing and designing events that really make an impact and really address the questions and interests you have. So you will find the link for a feedback survey in the chat, or you can scan the QR code on this screen. This will be a chance for you to share your thoughts about today's event and help us think about future events. And then we would also like to ensure that you have access to the resources, the many resources that were mentioned in today's session and event. And so you'll see the resource guide dropped in the chat once again, and feel free to take that and share it with others. It has a lot of links, some discussion questions that you can take back with you to reflect with you and your team, as well as the space to take notes. So we invite you to take that with you and share it with others. It will also be available on our event recap page in about a week or so. And of course, we invite you to continue learning and exploring. You can visit our website at khi.org to check out the 2025 Health on the Plains Coffee Hour, which was a series of 5 one-hour conversations with experts and leaders in rural health, as well as other federal policy updates and recent publications. And thank you again for being a part of the second annual Health on the Plains Summit. We appreciate your engagement and look forward to seeing you at next year's event. Thank you.